network because he could not come in person. So welcome to Dr. Hemanga Bhattacharya and please initiate your lecture and teach us. Thank you very much. Yes, yeah. Volume थोड़ा बढ़ा दीजिए यहाँ पे ये इसको थोड़ा सा टेढ़ा ऐसे करना पड़ेगा क्योंकि ये उधर तो कोई बैठा नहीं है, थोड़ा ऐसे करना। एक बार आप आवाज बढ़ाना
एक पैराग्राफ तू बोल, मैं बोलूंगी और उसके बाद तू
क्या लाभ है, किसको दिख रहा है?
हेलो हेलो
आवाज नहीं आई ठीक से। डॉक्टर हेमांग एक मिनट नहीं उसको बोल दी। डॉक्टर हेमांग अभी आवाज नहीं आ रही ठीक से, जस्ट सेटिंग दी। नहीं वो बोलते जाते।
Hello, sir. We are not able to. You are not audible, sir. Hello.
नहीं मैम वी आर
So we can request him to continue again after some.
हाँ डॉक्टर हेमांग एक मिनट रुक जाइए, यहाँ पे थोड़ा ऑडियो का थोड़ा प्रॉब्लम है। डॉक्टर हेमांग कैन यू हियर? हम साइलेंट हैं,
मैंने अनम्यूट कर रखा है।
जो हमें करिए ना अनम्यूट हमें। डॉक्टर हेमांग एक मिनट रुक जाइए, थोड़ा यहाँ पे ऑडियो का कनेक्शन ठीक नहीं हो रहा है। एक सेकेंड प्लीज प्लीज विल गिव यू अ सेकेंड प्लीज। ठीक करिए भाई। कैसे साउंड का कौन देख रहा है अभी? ऑडियो विजुअल डॉक्टर कासिम कौन देख रहा है यहाँ पे? देखिए आइए
सर एक सेकंड
हैं
डॉक्टर
आप लोग देखिए
नहीं
डॉक्टर
जो भी है आ जाए बेटा, आइए जल्दी देखिए। वो
Volume में है।
हाँ जी सर वो बोलते जा रहे हैं तो आधा लेक्चर उनका खत्म हो जाए। वो समझे मैंने बोल दिया, जैसे से वो सुनाई नहीं दी वो कर पैदा मैक्सिमम करिए ना। इसका कुछ होता है अप डाउन होता है। हाँ ये साउंड तो साइलेंट है। हाँ इसको फुल कर बेटा 90%। हाँ ठीक है
एक बार उनसे बोलो।
हाँ अब जरा एक बार अब स्टार्ट करिए। डॉक्टर हेमांग प्लीज स्टार्ट करिए। हाँ क्या स्टार्ट स्पीकिंग। हाँ गुड मॉर्निंग। हाँ यस ठीक है यस यस मच बेटर प्लीज। हाँ प्लीज बोलिए।
come up on stage.
Mishra sir, Maheshwari sir, and also to come up on stage. जैसे अभी वहाँ पे बोला सर।
थोड़ा बढ़ाइए बेटा।
नहीं लीड मत छेड़े, लीड ठीक है। आप अपना वॉल्यूम देखिए यहाँ से।
उसको फुल
फुल है?
हाँ
वॉल्यूम बहुत कम आ रही है।
देखिए
हाँ कम आ रही है लेकिन वो
वॉल्यूम बढ़ाए बेटा, मजा नहीं आ रहा।
स्पीकर्स की आवाज़ है क्या?
मजा नहीं आ रहा।
जो ऑडियो आ रही है ना इनका माइक से,
हाँ
या तो उनका माइक दूर है।
Dr. Hamang, can you come closer to your mic? Can you come closer to your mic, please?
And accordingly, I have prepared this presentation so that the next is as soon as next 15 to 20 minutes, I will try to cover the basic.
Can you come closer to your mic? Can you come closer to your mic or increase your amplitude?
हेलो
का म्यूट हो रखा है सर।
Sorry for the delay. Morning.
गुड मॉर्निंग सर, यू कैन स्टार्ट योर प्रेजेंटेशन.
Hello.
हाँ हेलो सर, यू कैन स्टार्ट योर प्रेजेंटेशन. यू कैन हेलो.
अनम्यूट कर रखा है हमने.
आप हो गए. हेलो सर, कैन यू हियर मी? यस सर, वी कैन ऑल्सो हियर यू. गुड मॉर्निंग सर, यू कैन स्टार्ट योर प्रेजेंटेशन सर.
Can you hear me now?
यस यस क्लियरली सर.
Very well. Clear?
यस यस, इट्स क्लियर. Yes sir, your presentation is again now visible sir.
So you can see my slides now.
Yes, it's looking nice. Yes sir. Please you can start sir. We welcome you sir on behalf of Subharti group, and sir please start your presentation sir.
Morning. Morning to all the esteemed my senior colleagues, at the outset, I would like to thank and the entire organization for giving me the opportunity to present this presentation. And I also acknowledge it to all of you from our
एक सेकंड.
I know bowel anastomosis is one of the primary challenges of all surgeons. And as a surgical accident,
नहीं हो.
it's very essential that you know where the treatment of bowel anastomosis. In next 15 or 20 minutes or so, I will try to give you a quick idea of what are the treatments of bowel anastomosis.
सर का यहाँ तक ठीक है. ठीक है, उसके बाद मेरे सर का यहाँ तक तो बोल दो, तो नीचे कम बोल. तो मतलब मैं बोलूँ थैंक यू सर वंडरफुल सेशन. आफ्टर ब्रेन स्टिमुलेटेड सेशन ऑन बाउल एंड anastomosis. फिर यहाँ से मैं तब तक ये बात
which determine a good and functional anastomosis, and also how anastomotic technique has evolved over centuries. And finally, I will highlight technical aspects of bowel anastomosis. I know there may be various variations on how bowel anastomosis can be performed, or there may be various different ways to perform bowel anastomosis. However, I would like to constrict myself here in these presentations to only to one or two types of bowel anastomosis, so that at the end of my presentation, residents do know at least one safe way to perform the bowel anastomosis. So I will not go elaborately on various techniques or various details. However, I'd like to pass on at least one safe way of performing the bowel anastomosis. I would mainly focus on the way that we perform a bowel anastomosis at our institute. So when we talk about bowel anastomosis, pathophysiology of bowel anastomosis, primarily all the pathophysiological research on bowel anastomosis are based on the model of skin healing. So anastomosis, whenever we talk about bowel anastomosis, it is like joining of one loop of bowel with another loop of bowel. And the mechanism on which the both joining of one loop with the other loop will take place largely resembles to the skin healing model. And most of the research on which basis based for to determine the pathophysiology of bowel anastomosis is primarily based upon the model of skin healing. However, whether it is skin or bowel, it's a human pathophysiology of healing process. So whenever we make an enterotomy or start joining one intestine with other, we first to make an enterotomy. As soon as we make an enterotomy, there is an inflammation, and that is the first step of inflammation, and platelets and neutrophil accumulate. The primary role of this cell recruitment is hemostasis, as well as platelet form a scaffold and also imbibe other cells for next phase of the healing. So platelet accumulations as well as aggregations form a scaffold at the site of injury and or site of anastomosis. And that scaffold actually gives nidus for subsequent formation of collagen as well as subsequent wound healing process. So, and that leads to imbibe of other blood cells as well as further inflammations and formation of collagenolasis as well as early phase of collagen formations. So this is the first event that happens within the first to third day of any bowel anastomosis. So, and during this phase, it is very essential that we maintain the continuity of bowel with certain artificial means. So all the cellular events do take place, but they need a certain, for anastomosis to maintain in structural integrity, we have to make certain amount of approximations. And that approximations we do with either suture or staples. So like skin healing model, the bowel healing model also progress in the same pattern. However, we need to keep those adhered or approximate them both the loops with artificial means, either the use of suture material or with the staplers. And this phase continues for first to third days. So we can divide the phases of anastomotic healing in three different phases. The first phase, which is very crucial and critical for technical standpoint, inflammatory phase. Then second phase is proliferative phase, where fibroblast and smooth muscle cells comes into play, and there is formation of collagen and collagen deposition and collagenolasis, so that the matrix type 3 collagen is removed to form a type 1 type of collagen type 1, which form the basic structure for fibrosis and subsequent wound healing. So this is the second phase, is proliferative phase, which takes place in day 3 to around 3 weeks, 2 to 3 weeks onwards. During that phase, the patient's biology as well as other environmental factors do play a crucial role. Then, finally, the remodeling phase, which starts after 3 weeks and might continue for years to follow. So these are the three primary phases of bowel anastomosis. First, there is the inflammatory phase, which for bowel anastomosis, it's a very technical phase of wound healing, because we need to keep the loop of the bowel approximated with artificial means. Second is a proliferative phase, and finally the remodeling phase, where the effectiveness or long-term outcome of bowel anastomosis takes place. And when we looked at by different models, within the first 2 to 3 days, a small bowel regains its strength, at the anastomosis regains the first week, the anastomosis is attains almost 80 to 100% of their burst strength. That means how much force will be required to separate those two loops which have been approximated. So if we have to look at in a different way, so I think all our residents should remember this slide, how the pathophysiology of a bowel anastomosis takes place, how a bowel anastomosis heals. The first phase is inflammatory phase. During that phase, all the platelets and neutrophils do play a crucial role to form the hemostasis as well as a formation of a scaffold on which the building material will get accumulated. And this inflammatory phase, or first 1 to 4 days, is primarily a surgeon's domain, because during this phase, body doesn't have much ability to keep the bowel apposed. So it is surgeon's technical skill or mechanical force that we apply will keep the bowel loop approximated. Subsequently, the other mechanism will take place in next 2 to 3 weeks time, which we call proliferative phase, where the adhesions, formation of collagen type 1 and other mechanism will help and bowel get approximated or adhered during this phase. And the final phase is a long-term phase which starts remodeling from second weeks onward. Sometimes this remodeling phase might continue years, and because of excess, sometimes because of failure of remodeling or excess, might lead to scarring of anastomosis also, which leads to anastomotic stenosis in long run. But however, this is the primary pathophysiology how a bowel anastomosis undergoes phases of changes over time to give us a very safe and effective anastomosis. The primary function of anastomosis is to maintain continuity of the bowel without compromising its function. A good healing, a good structurally constructed bowel anastomosis would definitely lend go for a almost normal bowel function. So this is about the bowel pathophysiology, how healing takes place when we make an anastomosis. There are various factors which influence this anastomosis and which, on basis of which the long-term outcome of an anastomosis is based upon. The classical and all of renowned factors on which a good anastomosis is based on are good blood supply. That means whenever we make an anastomosis, both the lobes of bowel should have adequate blood supply. Without adequate blood supply, entire process of pathophysiology of a bowel anastomosis will get disturbed and leading to a poor healing, which might lead to anastomotic leak or subsequent anastomotic stricture. Second is local as well as systemic perfusion. In many diseases where there is perfusion is hampered locally as well as systemic functions, local perfusion is essential. Thirdly, the anastomosis should be tension-free. Whenever we make an anastomosis which is under tension, that is likely to fail. That might fail immediately and might manifest as an anastomotic leak on the immediate short term, or it might show a formation of a stricture even if it fails in the immediate period. So anastomosis, a tension-free anastomosis is one of the primary technical factors we should look upon. These are the three factors which are based on overall patients as well as bowel supply. And fourth factor, which primarily on surgeon's domain to accept submucosa or includes submucosa in approximating the bowel. Submucosa of bowel is one of the strongest layer of intestine. It is essential that whenever we approximate bowel with bowel, we always do take care of taking submucosa into consideration. So these are the primary requisites or technical factors which good anastomosis. Good blood supply, systemic as well as local perfusion, and tension-free bowel lobes, and finally taking submucosa while taking the different suture bites. Then few other surgeons related factors are mucosal appositions. That means mucosa should, both the mucosa from both the sides of lumen should get apposed. And so whenever we make technically approximate the bowel, they should be watertight or airtight. And we should always try to excise or remove unhealthy or bowel. The anastomosis should be based on healthy as well as clean bowel edge. And there should not be any obstruction distal to the bowel anastomosis. That obstruction may be a mechanical or that may be a non-mechanical as well. So in broad sense, these are the few technical factors which govern a good anastomosis. If we meet at least most of these factors, anastomosis is likely to heal without any inadvertent or adverse consequences. There are, besides these technical factors, there are also certain patient-related factors which also influence a bowel healing process. Few of these technical patient factors are modifiable, like smoking, which is known to influence anastomotic healing. Similarly, alcohol, obesity, malnutrition, immunosuppression state, neoadjuvant chemotherapy or radiotherapy, anemia, malnutrition, all are known modifiable risk factors. By modifiable, I mean that these factors, if we do cognizant about, we can modify the patient. For example, the best way is to ask not to smoke for at least 4 weeks prior to surgery. Similarly, abstinence of alcohol and also losing body overweight or body weight might also help in anastomotic healing. So these are the modifiable risk factors which we should try in an elective case to. While there are a few other non-modifiable factors like male gender, elderly, systemic disease, emergency surgery. These are non-modifiable. We can't do much to change these factors. However, these are known to have influenced the outcome of a bowel surgery. And so we should always try that patient, to all those modifiable factors, we should try to modify them so that to make a bowel anastomosis more safer and more effective. So these are primarily different technical factors as well as other factors, patient-related factors, which influence bowel anastomosis. And if you are cognizant about, then only we can take preventive or improvise acceptance technical issues so that bowel anastomosis heals safely and give an effective outcome. When we looked at how bowel anastomosis takes place, over the centuries, the technique of during the older time for anastomosis, the approximation of the bowel were based on very crude ways. There are instances when people use hair or a teeth or horns of ants to approximate bowel with bowel, so that anastomosis takes place in due course of time. Subsequently, in recent past, the first scientific way of using sutures start with Lambert suturing, where he used a silk suture or a catgut suture to approximate bowel, or type of suture technique to approximate bowel with bowel. Over more than centuries, different types of suture technique has evolved. It was initially the Lambert, then subsequently Cushing, Sponel, Glemby, Glibert, Olsted. All are the known renowned surgeons who have modified the ways how we can approximate bowel, one loop of bowel to over bowel. And largely, all these techniques were based on different type of suturing techniques. I will touch upon at least 2 of these suturing techniques when we go in my subsequent slide about technical aspect of bowel anastomosis. So almost till 1976, it was a suture anastomosis which was primarily controlled, except Murphy's button, which has some approximation technique. However, in 1976, there comes a new era of use of staplers, and first single-use mechanical staplers were described in 1976 for bowel anastomosis. And today, most of the time, both techniques of anastomosis, whether we do open hand-chewing anastomosis or a staple anastomosis, both are equally effective and used most of the time. However, because of technical ease as well as ease of reproducing the technique, many a time we do more frequently a staple anastomotic technique. And of late, recently, we have few new ideas on how bowel anastomosis can be done, starting like sutureless device, magnetic rings, or self-gripping mesh are different technologies. However, I would like not to touch upon all those different advances. Rather, I would start sessions mainly on hand-chewn bowel anastomosis and also some technical aspect on staple anastomosis. So whenever we talk about, so this was the evolution, the factors that responsible for bowel anastomosis, and also how how anastomosis feels. And there are, as I started the talk initially, there are various ways of doing an bowel anastomosis. These are the three primary type of anastomosis or basic type of anastomosis that we do day in and day out. Nowadays, most frequently we do a side-to-side bowel anastomosis, where the approximation of the one antimesenteric border of one loop of bowel is made with antimesenteric border of the other loop. This is a side-to-side, we call side-to-side bowel anastomosis. And with the advent of staple anastomosis, most of the time we do a side-to-side anastomosis. When we anastomose one end of bowel with another end of bowel, that is called end-to-end anastomosis. During the time of open surgery and open anastomosis, most of the time the anastomosis were performed in an end-to-end fashion. However, as I told you, with advent or more popularity of staple anastomosis, end-to-end anastomosis has come down to a lesser extent because it is difficult to reproduce an end-to-end anastomosis with a stapler. Then the third type of anastomosis is side-to-end. That means we use one side of one loop of bowel to anastomose with another bowel loop, the end of one loop. This is a type of end-to-side anastomosis. These are the three primary types of anastomosis we do in our clinical practice. However, at least for today's lectures, I think I will primarily limit myself to side-to-side anastomosis so that at the end of these sessions, our resident can at least remember one way of doing a safe anastomosis. Side-to-side anastomosis is one of the most frequently performed anastomosis as of today. And this side-to-side anastomosis may be isoperistaltic or maybe antiperistaltic. So when we make an antiperistaltic anastomosis, that means this is the divided end of distal end of the one limb, and this is the proximal end of other limb of bowel. And when we anastomosis in this configuration, that both distal and proximal resected limbs are approximated, we call it antiperistaltic anastomosis. Most of the time it works as a functional end-to-side anastomosis because the content of proximal bowel are coming from this direction and the other limb are going from this direction. So functionally behaves as a end-to-side, but otherwise technically it's an antiperistaltic. When we call it an isoperistaltic, that means the content from the proximal bowel are moving from this direction, and also the distal bowel also moving from this direction. So that means the food time movement of bowel content remains in the same direction. That's why they're called isoperistaltic. These are two ways of constructing a side-to-side anastomosis. There are different thought process why they should be antiparasitic or why they should be isoparasitic and how it makes sense in long-term outcome. Those are different, very highly specialized discussion. But however, for a resident, it's essential that we know how antiparasitic anastomosis looks like, or how a construction of a isoparasitic anastomosis for bowel looks like. Then there are also various ways of reconstructing the bowel anastomosis, how we place suture, whether it should be an interrupted suturing or a continuous suturing. The both technique has advantages and disadvantages of its own. Like for interrupted sutures, it doesn't give a good hemostasis and also less water tight. But advantage is that integrity of depends on multiple sutures. So even if one suture breaks down, the anastomosis remain safe. While on continuous suture, it gives more water tight and hemostasis. But disadvantage is that may constrict blood flow because this is a continuous anastomosis. So might lead to this dehiscence or ischemia. However, most of the studies has shown continuous or interrupted both as a safe and effective technique. So most of the time it becomes more of a philosophy now. If someone has been trained to perform anastomosis with continuous suturing technique, then they should master the technique well and should continue learning, doing, and teaching the same technique. Because whether we do interrupted suturing or continuous, both techniques are going to give us almost similar results. Similarly, there has been difference of opinion whether we do a single layer or double layer anastomosis, but by and large, both techniques are equally effective as far as anastomotically perioperative complications, length of hospital stay, mortality, all have been taken care of. So, in next few slides, I will touch upon different few technical aspects of suturing and how the suturing should look like and how technically we construct a bowel. So these two parameters like interrupted suturing, continuous suturing, single layer, double layer hardly make much sense. So idea is to train one technique safely and effectively and start reproducing the same technique again and again. Then there has been various techniques, as I told you. It started with Lambert suture and subsequently there are various techniques how to take it for approximating the bowel. However, two suturing techniques that we always follow, and most of the time we do anastomosis using these two suturing techniques. One suturing technique is Lambert suture. It's a seromuscular stitches. What that by seromuscular we mean that we won't make it full thickness, needle won't pass full thickness. It will pass from one side of the bowel lumen, penetrating only muscular and submucosa, and also on the other side, serosa, muscularis, and submucosa without penetrating the mucosa. The advantage of this type of suture is that the mucosa is never pouted out. They are always get inverted. So there is, and that's why the serosa is approximated well. So this is Lambert suture to approximate the serosa well. And this suture doesn't, it's not a full thickness suture. It takes the serosa, mucosa, and submucosa of both the lobes so that at the end, serosa to serosa approximation is maintained. So this is one technique of suturing that we always use for approximating the bowel. This is Lambert suture, which is a seromuscular suture and helps in maintaining the serosa to serosa contact. Other suture is Connell suture, which is mainly to mucosa. So how it may be a it's a full thickness suture. We come from outside from the serosal side outside in. It's a full thickness suture, and again at that 2 to 3 millimeter either vertical axis or horizontal axis, needle will come again from inside out, full thickness. So this is then again on the other side the same way from outside in, inside out. This is a full thickness suture. The beauty of this cornel suture is that it invert the mucosa so that mucosa doesn't comes out or mucosa become always inverted. So Lambert suture and cornel suture are the two suturing techniques. I would suggest for a resident that they master this technique and start doing while doing a bowel anastomosis. These two suturing techniques will play a big role. There are other suturing techniques as well. There are various techniques called extramucosal techniques, subserosal technique, Grapill's technique, Cushing's technique, or many other techniques. But I would definitely suggest that learn at least two techniques and go on doing those suturing techniques again and again so that you master this technique. Both, almost all different types of suturing techniques are very specialized techniques, but at least these two suturing techniques are easy to learn and easy to replicate also, and gives a good results for bowel anastomosis. So in next few slides, whatever videos I will demonstrate will be based on Lambert suture as well as cornel sutures. These are the two suturing techniques that I always train my residents to while doing a bowel anastomosis. So, for technique of bowel anastomosis, I will rather come to this. Suppose for anastomotic technique, suppose we are doing a open side-to-side anastomosis. This is one limb of bowel. This is the another limb of bowel. The first part is to approximate this layer. It is seromuscular stitch with Lambert stitch. We also call posterior layer or fourth layer of bowel anastomosis. Here we approximate the serosa with Lambert suture. This can be done with continuous sutures or interrupted suture. That personal choice. Most of the time we do a continuous Lambert suture, which is a serosa, essential for serosa to serosa approximation. This is the first step of making a bowel anastomosis. Once we approximate the serosa to serosa, we then make an enterotomy here as well as here. The remaining now it looks like here, and that loop of bowel is now shown over and over continuous suturing technique. So this is called posterior inner layer or third layer of bowel anastomosis or side-to-side anastomosis. This is the third layer. Then once we approximate both the posterior and third layer, at this angle we start cornel suturing for the anterior part of the layer or second anterior layer. Here from one angle we start corneling, and at the sutures the mucosa gets everted and a good approximation is done. Then the fourth layer again, once it is done, we start the seromuscular Lambert suture, fourth layer of bowel anastomosis. This is the one primary technique of bowel anastomosis. Most of the time in the emergency or in a regular activity also, if resident is well trained or have seen this technique done for once or twice, they can replicate the technique safely for technical consideration of a bowel anastomosis. As I told you in my first slide, that this is the first to third day or up to 3 to 4 days where this suturing technique plays a very critical role on safe bowel anastomosis. Because during this time, the body's ability to maintain the bowel loop approximated is very nominal. So it is essential that a good suturing technique is adopted, which is neither too tight nor too loose, and make watertight or airtight with good approximation. That means approximation of the serosa and serosa, apposition of the mucosa to mucosa, and on each bite we should include the submucosa, which is the strongest layer of anastomosis. And for that, fourth layer will be with Lambert, third layer with continuous Trojan suture, second layer will be Cornell suture, which is outside in, inside out, on both sides. That will, and finally again Lambert suture for serosa to serosa approximation. This is the primary technical details that we should always remember for a bowel anastomosis. Now let's see one. So, and while doing this bowel anastomosis, we take a continuous suture, interrupted sutures, or that's primarily depend upon your personal choice. So this is one small video of open bowel anastomosis. So you can see this is one loop of bowel, a small bowel, and this is another loop of small bowel. We have to do the we are planning to make it side to side small bowel and chin anastomosis. We already take one stitches approximating the both the lobes. This is the fourth layer of bowel anastomosis. That means this will be a Lambert suture. So we are taking the seromuscular bite one after the other. So this needle comes from one side on one loop of bowel, seromuscular stitches to the other side, and we will maintain the seromuscular stitches till around 4 or 5 centimeters or 6 centimeters according to the of bowel to be anastomosed. So these are the seromuscular bites. And then once the fourth layer is done completely, this is the fourth layer, the seromuscular approximations, continuous suture. We make an enterotomy on both sides of the bowel. So here is the enterotomy around 3 to 4 millimeter from the seromuscular stitch line. The on one side it has been so this is the one layer that opened up one side. This is the other side. Here already we have made the serosal approximation. Now we'll start the third layer or third posterior layer. This will be a through and through posterior layer, a full thickness continuous suturing technique. So at one angle we take a cornel sutures, then we'll continue it as a over and over continuous suture. Here we are using, there are various opinions on types of suturing, suture we need to use. Most of the time we use a monofilamentous PDS suture. So this is the third layer of side to side bowel anastomosis. This is a continuous over and over suturing technique. So we complete the third layer up to here. Now again we come to the end of the one angle. At this angle, we will now start taking a cornel suture so that the mucosa gets inverted completely. For cornel suturing, we will come from outside in, then again from inside out on one side, then again on the other side, the same will be repeated from outside in and inside out. So with outside in, inside out, as you pull the thread, the mucosa will get inverted completely. There is no eversion of mucosa, and also get a good approximation. So, and also the vascularity of the bowel is remain very much uncompromised. So at the end of the complete cornelling suture, so once we take the cornel suture from one end, we'll come to this end. That completes the second layer or anterior second layer. That's a cornel suture. And once we gone up to that part, again we'll take a Lambert suture or fourth layer of the suturing technique. So at the end of the surgery, this is the fourth layer already been placed, which is a Lambert suture or cerebromuscular suture. All the anastomosis is taken care of. This is around 6 to 7 centimeter side to side hand-sewn anastomosis. At this phase, we can also palpate with both the fingers to see the patency of the anastomosis. So this is the primary type of hand-sewn anastomosis technique, which is based on the principles of four-layer anastomotic technique. First, Lambert suture, continuous, also called fourth layer or posterior. Third is a layer, or third layer is over and over continuous suture. Third layer or second layer or anterior layer is corneal suture, so to avoid mucosal pouching. And finally, the first layer is again from cerebromuscular Lambert suture. So at the end, this was how we do a hand-sewn side-to-side bowel anastomosis. So most of the time nowadays we also do a staple anastomosis. The technique of staple, how they make anastomosis, is almost same. They also approximate the serosa to serosa while divide the lumen on one side. So in staple anastomosis, what we do, same way we approximate one loop of bowel with the other, then make an enterotomy on both the sides of the bowel. So we make an enterotomy here as well as enterotomy here. Then we pass on the blades of stapler on one loop, other on the other loop, and compress, and finally do the machine or stapler machine approximate the bowel loops one another. At the same time, they also divide the bowel from inside. So that's how they make a continuous channel like this anastomosis at this point. So at the end, once we remove this stapler, this segment will look like a small enterotomy. And the same enterotomy is closed exactly the way we do for anterior layer of open suture. That means corneal suture. Then finally we do a Lambert cerebromuscular stitches to close this anastomosis at this point. So this is a small video how we do a open staple anastomosis. So this is one loop of bowel which needs to be anastomosed with another loop of bowel. This is one loop of bowel, and other loop of bowel is this one. We have already performed the resection, and now we are ready to do the anastomosis. So first part is to make a small enterotomy and the antimesenteric border of the bowel. We make a small enterotomy which is now slightly annular so that the stapler blades can pass on. This is the other loop of bowel. So this one stapler anvil is passed on to the one loop of bowel on its antimesenteric border. And the other blades of the stapler is now passed on along with the other loop of bowel. The both the staplers are now approximated. At this phase, so this is one loop of bowel. This is the other loop of bowel. The stapler is inside, and we have now compressed the stapler and are ready to deploy the stapler. So we have fired the stapler gun, and that makes a complete anastomosis. So this is the the enterotomy through which the staple was put on. This needs to be closed very meticulously, almost the same way we do first and second layer of open bowel anastomosis. So this is one end of this enterotomy, which will be repaired with corneal suturing so that the mucosa gets inverted adequately. So with corneal suture, we approximate the invert the mucosa, and then take a cerebromuscular Lambert sutures again for adequate serosa to serosa approximate. So whether we are doing a staple or anastomotic technique, the basic steps of anastomosis is same. So for enterotomy closure, like in open hand-sewn anastomosis, we do first the corneal sutures to invert the mucosa, then approximation, seromuscular approximation with Lambert suture. So this was the full way how we do a staple and open staple anastomosis. All other principal parameters like good vascularity, tension-free repair, good and meticulous dissections will remain same whether we do open or staple anastomosis. Staple makes it little easier and more reproducible technique. Otherwise, they also do the same technique what we do the open way, that is approximation of the bowel. The staple anastomotic repair, the enterotomy which has been created, there are various different ways to close this enterotomy, but we normally perform with the open closure of the enterotomy, exactly same way we do the first and second layer of open hand suture anastomosis. So this was corneal suture first, then on top of Lambert seromuscular suture for adequate serosa to serosa approximation. This was the hand staple open anastomosis. Nowadays, with advent of laparoscopic surgery, we do bowel anastomosis completely laparoscopically also. For laparoscopic anastomosis, we have to rely largely on different stapling devices. This is how a stapling devices looks like. So open anastomosis, it is a shorter version. What I have just now shown. In laparoscopic version, they are longer because the abdomen is distended. And exactly the way we do for open anastomosis, one anvil of the staple will go to the one limb, other anvil will go to the other limb, and they make the anastomosis. So this is like a gastrojejunectomy. So we have made small enterotomy on both on stomach as well as on the other bowel. For this enterotomy, the jaws of anvils are inserted and they are compressed, and finally the anastomosis is made. And at the end, this site where we make the enterotomy needs to be closed. There are various ways of closing. There is one way to close is using another stapler, but in our clinical practice, we follow just exactly the same way we otherwise would have done for an open anastomosis. That means closure of this enterotomy using one corneal layer of corneal sutures to invert the mucosa. Then on top of it, another suture technique with Lambert suture to approximate the serosa to serosa. So that whether we do an open anastomosis, open staple anastomosis, or laparoscopic anastomosis, everywhere we follow the same technique or same way of performing the anastomosis. So that technique becomes standardized and everybody do it repeatedly on repeated occasions, and well, every one of the team or surgical team are well versed with how we perform the anastomotic technique. So this is a small video of how we do a laparoscopic bowel anastomosis. So this is one loop of this patient is the anastomosis between small bowel and second part of the duodenum. So this is a duodenojejunal anastomosis. So this is the loop of jejunum. First thing is to make a small enterotomy on the jejunal wall, so that so this enterotomy is enlarged with instrument, so that our staple anvil goes in. So this is on one side, and similarly we make another small enterotomy on the other side. Once the enterotomies are made, the jaws of blades, staplers, needs to be inserted to the bowel very gently. So here we have placed one jaws of the stapler. Now we place the other jaws of the stapler. Once it is done, the staple is fired, and this is the common enterotomy, or the site where the staple goes in. Now we will follow the same technique of closure of this enterotomy, that is the corneal sutures, outside in and then inside out. Now again outside in and inside out. This is now we are performing the inside out. So this way of doing corneal sutures will safely invert the mucosa. The suturing will be outside in, inside out, around 312 to 4 millimeter away from the edge. So this is the closure of the enterotomy by two sutures with corneal sutures. Once the corneal part is done, then we will follow the same technique of Lambert suture, which is a seromuscular suture for adequate serosa to serosa approximations. Now all these sutures will approximate actually the serosa of one loop of bowel with the other loop of bowel. Remember, the principal tenets of surgery is the same. We have to approximate serosa to serosa, and also the needle bite should take in account the presence of submucosa, which is the strongest layer of the bowel. So as I have shown, whether we do a open ensuing anastomosis, or we do a staple open anastomosis, or a laparoscopic completely staple anastomosis, the basic tenets remain same. All anastomotic needs to follow the same physiological concept that there is adequate approximation of serosa and mucosa should get well approximated and should be inverted. So, there are various different types of bowel anastomosis. Whether we do a gastrojejunostomy with anastomosis between stomach and jejunum, or a anastomosis, or even a ileorectal anastomosis. We always follow the same steps, same side bowel anastomosis. That means we approximate the bowel, check that they are adequately approximated under tension, the vascularity is well protected, and then we approximate them with side-to-side anastomosis. The enterotomy that's created for entering the staple are closed using the same technique repeatedly and every time. We close it with first layer of corneal suture, outside from serosa to inside to the inside the lumen, then from inside the lumen to the serosa, that is outside in, inside out on both sides. That inverts the mucosa completely. Once mucosa gets inverted completely, we take care the serosal approximation with Lambert seromuscular sutures. As I told you again, I would like to re-emphasize that there may be various other techniques of bowel anastomosis, but at least we should know one good technique of doing the approximating the bowel, and we should be well versed with that technique, while other technique on a special occasion we might adopt, but most of the occasions we can well accomplish the task of approximating the bowel loop by performing a side-to-side bowel anastomosis. So, to conclude, Chairman Sir, ladies and gentlemen, and all my residents over there, I would say that anastomotic healing is another type of tissue healing. It follows the same principles of tissue healing, that is the phase of inflammation, then stage of fibroblasts, and finally stage of remodeling. All those phases are same. In the first phase or stage of inflammation, these are the technical parameters which plays a crucial role. And at that phase, we have for about that 3 to 4 days, the bowel should be adequately approximated with mechanical means, that is either suture or staplers, and all other principles of safe bowel anastomosis remain unaltered whether we do open or staple anastomosis. That means the anastomosis should be tension-free with minimal contaminations, and the bowel loop should have good blood supply for a safe healing of bowel. Whether we do hand tune or stapler anastomosis, both the techniques are of similar efficacy. It's not that hand tune techniques are inferior than stapler. Of course, stapler anastomosis makes things easier and it's often faster to pop. And specifically in occasions where it's difficult to access, for example, deep in the pelvis for colorectal anastomosis or up in the higher chest for esophagogastric anastomosis. Those areas is very difficult to access by open technique. So obviously they are difficult to execute a safe hand suturing technique. In those difficult areas, staple definitely has a significant role. But in all other areas, whether we do staple or open hand suturing and technique, all had same outcome. Whether we do a single layer or double layer, whether we do a continuous suture or a intrapid suture, all literature suggests both the techniques are equally effective. It's the way you have been trained to perform an anesthesia. It's like more of a school of thought. Like if someone has been trained to perform continuous suture, he should go on practicing same technique again and again, because it is the art of bowel anastomosis which can be mastered only after repeated practice. And with repeated practice, everyone can form the required skill to perform a safe anastomosis, irrespective of suture material we are using, technique we are using. It's the skill of the surgeon which has been honed over time actually make difference in long term as well as early outcome following an anastomosis. With this, I would like to conclude my lectures. At the same time, I would also like to invite all the residents as well as faculty members for our workshop on coloproctology, which are planned for 9th of March. Here we have 1 day of different hands-on workshop on different techniques of various anastomosis techniques, both on animal tissues as well as silicone or artificial tissues, with hands-on activity for bowel anastomosis. I would definitely like to invite all of you to take part in that workshop. Thank you very much.
Thank you, sir. Thank you for this deep, giving this deep knowledge in such simple presentation. Any questions? Please, sir, please.
Dr. Hemanga, wonderful presentation as always, and we very much appreciate your effort and time taken for this very thought-provoking, detailed representation and teaching. 2 questions. One is, you said that the single layer anastomosis gives the same result as double layer. Then why bother doing double layer? You're taking more sutures, more time, increasing the cost.
Excuse me.
Dr. Hemanga, सुनाई दे, clear आ रहा है सुन? Can you hear me? या उस?
Hello.
हाँ. Dr. Hemanga सुनाई दिया आपको? Hello? Hello? इससे?
Unfortunately, sir, I can't hear you.
हाँ, okay. Can you hear me now? Can you hear me now? Yes? Hello? हम लोग म्यूट तो नहीं है? म्यूट तो नहीं है? अब सुनाई दे रहा है आपको? हेलो डॉक्टर हेमांगा?
आवाज आ रही है हमारी?
हेलो डॉक्टर हेमांगा, कैन यू हियर अस फ्रॉम सुभारती फ्रॉम मेरठ? नहीं.
Hello.
हाँ, अब सुनाई दे रहा है?
No, I can't hear you.
अच्छा, हेलो. हाँ, फोन पे बोल दें?
हाँ सर, फोन पे आपकी आवाज आ रहा है.
ठीक है. तो क्वेश्चन है एक, इफ द रिजल्ट्स of the large studies and even randomized trial meta-analysis show that the single layer anastomosis give the same result as double layer, then why bother doing double layer anastomosis, taking more time and using and probably wasting more suture and increasing the cost of care and time to surgery? Why not just do single layer? Dr. Theodore Cocker, the famous thyroid surgeon, the first Nobel laureate in surgery, said, do the minimum necessary. Do the minimum necessary. So if one layer is doing the job, why do two layers? That is question number one. And question number two is, some time ago in Britain, it was becoming very popular to do single layer seromusculo submucosal mucosa excluding interrupted suture, where you do not appositional, it is appositional, no inversion, no eversion, mucosa excluding, single layer seromusculo submucosal. So what are your thoughts about it? And it's interrupted, usually interrupted.
Okay.
And there were many trials also
Regarding
conducted for low anterior resection, coloanal anastomosis, and also for esophagus.
First question, whether a single layer and double layer technique, there are difference of opinion how we should make anastomotic technique. There has been various literature search, various technique of ways of doing things, but overall, the latest meta-analysis says whether we do single layer or double layer, both techniques are equally effective. This was that means the leak rate and periodic complications and length of hospital stay and mortality are same.
Right.
While saying so, I do agree that double layer technique might have a disadvantage of increasing operating time, increasing the suture length of suture and cost of the material used. So from that standpoint, we can say that single layer is more effective, more cost effective. However, the outcome of anastomosis, when we look at the effectiveness, it is the anastomotic leak, periodic complication and length of hospital stay. Both are same. That's why I take it in a differently, that this is more of a school of thought. If somebody has been taught to perform a single layer anastomosis technique, he should go on performing the same technique repeatedly. Yeah. If someone has been trained on double layer anastomotic technique, he should do it repeatedly, because the end of the day, it is the anastomotic leak and postoperative complications which makes surgery more eventful. So both the techniques gives equal results when we talk about safety of an anastomosis is concerned. Same way, the other question of yours, whether we do a submucosal, extramucosal anastomotic technique, these are different variations of how we do anastomosis. Yes, extramucosal by single layer is as effective as full thickness double layer technique also. However, technically that is more expertise is demanding and more expertise is required. So whatever I have shown is primarily intent for a resident. The way I have shown, it's easier to replicate, easy to learn. So, and same way that also give you a good result on the immediate post-op period. That's why I have been saying that whether it is single layer, double layer, full thickness, or extramucosal bite, all techniques equally efficacious as soon as other parameters or other physiological parameters are taken in care of. So when we have a good physiological parameters like tension-free, good vascularity, good meticulous tissue handling, all techniques give almost equal result as far as anastomotic leak rate is concerned. So idea is to train residents at least one safe way of doing things so that they can replicate the techniques during their early clinical practice or emergency team, and then subsequently go on improvising their technique as they master on the subject. So most of the time for resident training and purpose, we do the way you have shown it. At the same time, I do agree that there are variations of technique and there are difference of opinion on superiority of one technique over other. But while we talk about effectiveness, all the techniques gives out same effectiveness. Sir.
Thank you. Thank you, Dr. Hemanga. Thank you. So,
Again,
for
I
the
can't hear
residents,
you, actually.
yeah, thank you, Dr. Hemanga. So, for the residents, they should appreciate that interrupted suture causes less ischemia, right? And all staplers are interrupted. All staplers are interrupted. So, they are maintaining some blood supply between the two staples or between the two sutures. And if you look at the coloanal anastomosis, where the blood supply of the lower anal segment is very precarious, there is no serosa, true serosa. And similarly, in the esophagus, there is no true serosa. So, in these two areas, most surgeons perform interrupted suture, and staplers are always interrupted. So, taking these 2 points, I think we should prefer interrupted compared to continuous, because it will cause less ischemia. And if single layer is saving time and saving suture, at least in the cost-conscious society, we should be saving money. Thank you, Dr. Hemanga. Wonderful presentation.
Sir, just a
We
comment
learnt
on.
a lot.
Sir, just a comment on your statement. I think what matters most is the safety. Whatever teaching has been done in single layer anastomosis meticulous and patient to that extent to learn the technique, to master the technique. Ultimately, the costliest thing is an anastomotic leak. So a suture here and there doesn't matter till you don't cause a ischemia, a leak. It is the technique, it is the patience of the surgeon, it is the condition of the bowel, and ultimately God's grace that your anastomosis doesn't leak. Because leak is the costliest thing to have in an anastomosis. I think that is the take from my side. Thank you, sir.
लेफ्ट कर दे.
So no further question. Sir, we should proceed further. Huh?
Mang sir ने left कर.
Sir, वो. Thank you.
Thank you, everyone. I request Dr. Rakshap sir to felicitate Dr. Nivesh Agarwal.
Yes, sir.
Thank you, sir, for the gesture. Now we request Dr. Sanjay Pandey, sir, to please come up and felicitate Dr. Nivesh Agarwal, sir.
हाँ भाई
Now I request Dr. Ashok sir to please felicitate Dr. M.K. Maheshwari sir.
Thank you, sir. I request Dr. Madhubala ma'am to please come up and felicitate Dr. Shashank Mishra, sir.
Well, coming to the end of our first breakfast.
चलो इसको तो यहीं रख दो ना, अभी क्या करेंगे। तुमने मुझे पहले निबेड़
anastomosis.
नहीं, अगर जब जितना डेटा है रैंडमाइज ट्रायल मेटा एनालिसिस सब दिखा रहे हैं कि सिंगल लेयर इज इक्वल टू डबल, तो सिर्फ सिंगल क्यों नहीं?
Sir, my simple thing is कि by doing second layer, I am very much comfortable. The layer is inverting. The mucosa is inverting. नहीं, वो- but the mucosa should invert, in my opinion. Any inversion of mucosa will lead to leakage.
एक्सक्लूड द मिकोजा, मिकोजा अपने आप इन्वर्ट हो जाएगी. इफ यू डोंट टेक द बाइट, मिकोजा आप स्वयं से इन्वर्ट हो जाएगी.
Yes, definitely, sir. But I am not used to those stitches. That is the thing.
1991 में हम लोग MS कर रहे थे तब ये इशू होता था and most of the experts they overwork. But you require great expertise for that.
Fast.
Next, I would like to invite on stage our Dean of Subharti Medical College, Dr. Pradeep Bharti Gupta sir, who is a renowned neurosurgeon by profession and who is known for his sincere, empathetic professional conduct with an experience of nearly 35 years in field of neurosurgery. Sir, we request you to kindly come on stage and grace us with your presence.
Thank you, sir. Now we request another eminent personality, Dr. Shashank Mishra sir, Head of Department of General Surgery, Subharti Medical College, a prominent name in the field of minimal access and laparoscopic surgery, and has many renowned publications and awards in his name. Thank you, sir.
Now I would like to invite on stage our very own Dr. Aditya Rastogi sir, whose continuous efforts have made this day possible.
He is the organizing secretary of the event and is currently practicing in Subharti Medical College as associate professor. Sir, we request Dr. Anurag Srivastav sir to please come up and grace us with your words.
Jai Hind, Namaskar. Welcome to our dignitaries on the dais, Honorable Vice Chancellor, sir, Honorable Principal, Subharti Medical College, Honorable Head Department of Surgery, Dr. Shashank Mishra, and Dr. Aditya, our Organizing Secretary, Honorable Senior Medical Superintendent, Brigadier Menas, sir, and dignitaries from Professor Khare, Vice Principal, Subharti Medical College, Dr. Nivesh, Head Department of Surgery, Karnal Government Medical College, Dr. Ashok Sharma, Senior Professor of Surgery from Safdarjung Medical College and Bardwan Mahabir Medical University, Dr. Kulshresht, and all the eminent professors, speakers, my dear sisters and brothers, and dear students. It gives me immense pleasure to honor our chief guest and the dignitaries on the dais and all of you on the Day 1 inaugural function of the Subharti Surgery Update Year 2024. This year we are celebrating 24th year of the inception of the Department of Surgery, which began in the year 2000. And some of the old faculty members are here, like Dr. Sanjay Pandey and Dr. Maheshwari. They have been here with us since the inception of this medical school. So the Department of Surgery is performing great surgical care and research and teaching in the field of general surgery and some of the super specialties also, like plastic surgery, pediatric surgery, urologic surgery, which is part of the general surgery. And of course, the neurosurgery is now a separate discipline now. So we are conducting regular continuing medical education or CMEs and operative workshops. And this recent workshop was held on cadaveric hands-on training. And we have acquired a new technique of soft embalming in the Department of Surgery, thanks to Professor Khare, the Head Department of Anatomy, and our Vice Chancellor, who has acquired this skills in performing the soft embalming. And the first workshop was conducted recently, about 2 months ago, and we'll be conducting more such workshops, hands-on workshops. So surgical technique is a skill-driven department, and here we have to become adept and skilled in performing psychomotor skills like operating and suturing. So today's theme is anastomosis of the bowel, creation of the stoma, and various bowel-related operations. So we had the first lecture here on online mode by Dr. Hemang Bhattacharya from All India Institute of Medical Sciences, New Delhi, who is an expert in abdominal surgery and actually a PhD in minimal access surgery from University of Tübingen in Germany. And this was followed by very interesting discussion. So I again take great pleasure in inviting you all for the inaugural session of this surgery update year 2024. Thank you.
Thank you so much, sir. Now I invite Dr. G.K. Thapliyal, sir, to please enlighten with some words.
Jai Hind. Dignitaries sitting on the dais, especially Principal of Subharti Medical College, Dr. Pradeep, Organizing Chairman of the conference and update, Dr. Professor Anurag Srivastava, Organizing Secretary, Head of the Department of Surgery, dignitaries sitting in the hall, Vice Principal Medical College, Dr. Satyam Khare, our Senior Medical Superintendent, Brigadier Minhas, invited guests, faculties of Subharti Medical College, all PG students from Subharti and from other medical colleges from the NCR region, and all our resource persons. A very good morning to you all. And on behalf of Swami Vivekanand Subharti University, it is my proud privilege to welcome all the participants and invited guests who have come from different states. I was told about students and faculty from 8 states are participating in this update. And in the morning you had an online program which was delivered by the renowned faculty from the AIMS, who is currently in the US. When I was going through the program which are being deliberated upon, and I was amazed to see that it's a complete mixture of everything, which knowledge, skill and aptitude, which is the requirement for any student to grow or any professional to grow in his or her field. Ladies and gentlemen, there are 4 words we must know, and 4 words like intelligence. First comes intelligence, second comes wisdom, third comes knowledge, and fourth comes skill. If these 4 we understand very well and we dwell upon these 4 areas, so that results us in a perfect human being and perfect professional. And the current buzzword which is going on in the education sector or in the country, particularly after release of our new education policy, that is the lifelong learning, which is now happening and which is being focused in each forum wherever that education is discussed. This is the new in the education sector, but if you talk about medical education, it has been right from the beginning. Unless you learn throughout your life, you cannot become a successful professional or successful practitioners. So you have to learn throughout your life. And this learning comes from either from the reading the books, either listening some seminars or attending seminars, conferences, updates like this, and improving on your skill, like attending some workshops, attending some live surgeries. All these things, skill will come. And basically you all are intelligent, born intelligent, because you are a chosen the medical professional. You have come through a very tough competitions, and that intelligence is there, which is God has given to you. Now on that, based on that intelligence and skill and knowledge, you have to develop that wisdom. Where to use this knowledge, in which way this knowledge should be utilized the best, that is the wisdom. And that wisdom comes with your experience. And in this forum, there are many experienced surgeons who will be sharing their experiences, not only through books, but their own experience. That is a very, very important thing. And I urge all young students, please make it a habit. Anything happen in your during your journey, professional journey, every day is important. Every day experience should be noted, should be recorded. And when you record everyday experience, it becomes a big volume by the time you reach to this age. So it's my earnest request, don't take anything, any event or any incident happening in your professional journey as just a light one. Keep recording. Now you have a photograph, you have camera, you have everything with you. So everything keep recording. And when you go home and you, after 1 week or after one year, you just go through that, whatever you recorded during whole month, it becomes a big knowledge bank. So that is a very, very important as you keep growing in your life, you keep learning throughout life. I wish you all the best and great future ahead and a great success for the event. Thank you very much. Jai Hind.
Thank you so much, sir, for such motivating words. Now I take this opportunity to call on stage our principal, sir, Dr. Pradeep Bharati Gupta, sir, to kindly grace us with his words.
Thank you. Honorable Vice Chancellor, sir, Dr. Anurag, Dr. Shashank, Organizing Secretary, just for Aditya, Dr. Minas, Satyam, Nivesh, and all my colleague faculties over here, Sanjay Pandey. I am omitting doctors because they are my younger brothers. So I am saying all these names. My dear students, learning never ends, as our Vice Chancellor has said. Even if you pass out, every day will be change in technology, which is good today will be obsolete tomorrow. And you are fortunate enough to have internet and those things to learn daily. Now knowledge transmission is so fast through internet that what is happening in US yesterday will be available to you yesterday only. It will not be tomorrow. So be abreast with the latest knowledge. They are organizing good lecture series abroad also, which is again a learner for everybody. And you should keep on learning, and practice will make you perfect. Everybody has made a very good effort to make this conference a success, especially the Organizing Secretary, Dr. Aditya, and everybody, Dr. Anurag, sir. So my best wishes, and in last, if there is any shortcoming in this conference, I take the onus of that shortcoming, being the Dean and Head of the institution, that please forgive us for any shortcomings. If there is something over there that you're not being looked after properly, or there's any other issue, we'll definitely try to resolve it. My best wishes. Thank you.
Thank you, sir, for such nice words. Now, I would like to invite on stage Dr. Aditya Rastogi, sir.
Good morning to all. I deem it a great honor and privilege to propose the vote of thanks on this occasion. First and foremost, I thank our chief guest, Honorable Major General Dr. G.K. Thapliyal, sir, who despite his busy schedule has found time to grace this occasion. We are grateful to our organizing chairman, sir, Dr. Anurag Srivastava, sir, for his words of encouragement. I thank him for his kindness, his interest and continued support. I thank Principal, sir, Dr. Pradeep Bharati, sir, for his support in organizing this CME. My heartfelt thanks to HODs of various departments and faculty for their valuable contribution, guidance and encouragement. I thank all the distinguished invitees present here for accepting our invitation. Last but not the least, I thank my colleagues for their hard work to ensure that this CMA becomes a memorable success. Once again, I thank you all for your attention. Thank you. Now I hand over the mic to Dr. Sampurna to proceed with the inauguration ceremony. Thank you.
It takes years of hard work to wear this prideful badge of being a doctor. No doubt there is some invisible divine force that help us become the best versions of ourselves. So let's proceed by taking blessings from the Almighty.
For lighting the lamp, ceremony, I would like to invite our chairperson, Dr. Anurag Srivastav, sir, our principal, Dr. Pradeep Bharti Gupta, sir, our vice chancellor, Dr. G.K. Thapliyal, sir, our vice principal, Dr. Satyam Khare, sir, medical superintendent, Brigadier Dr. H.S. Minhas, sir, and DMS Dr. Krishnamurthy, sir, and our esteemed professor, Dr. Sanjay Pandey, sir, M.K. Maheshwari, sir, and Shinshak Mishra, sir. Thank you, all of you. Now, I would like to invite Dr. Anurag Srivastav, sir, to felicitate our CEO, Dr. G.K. Thapliyal, sir, and Dr. Principal, Dr. Pradeep Bharti, sir. C is not present here. I would like to invite Dr. G.K. Thapliyal, sir. Now I invite Principal Dr. Pradeep Bharti, sir. I would also like to invite our Vice Principal, Sir Dr. Satyam Khare.
Now I request MS sir to please come up on stage for the felicitation. Thank you, sir.
After this brain-stimulating session on bowel anastomosis, I would like to invite Dr. Nivesh Agarwal sir on stage to deliver his talk on stoma creation.
Dr. Nivesh Agrawal sir has been president of Haryana chapter of ASI 2023 and is currently heading the Department of General Surgery in Kalpana Chawla Government Medical College, Karnal. We are glad to have you here, sir.
Thank you so much. After again coming Subharti, I have worked here for the 10 years and coming again and again, it is a very nostalgic feeling. And with that, I want to invite my moderators, my chairpersons. Chairpersons, are there any? Or shall I start? Chairperson.
As a chairperson, I would like to invite Dr. Vipin Agarwal sir and Dr. Dheeraj Balyan sir. Dr. Dheeraj Balyan sir, he is the head of department at Lala Lajpat Rai Medical College, Meerut. And Vipin Agarwal sir, he is the professor in the Department of General Surgery in IDST Medical College, UP.
Slide changer है इसे करना है.
So this is the laser pointer. The pointer की जरूरत नहीं
Pointer जो नहीं slide changer है इसमें.
हाँ slide changer चाहिए सर.
ये से कर लूँगा कोई बात नहीं. No. So thank you again, and with permission of my moderator, my chairperson, shall I start with the topic? I'm thankful that this topic has been given to me, which is this topic is very much being basic when residents comes to the department, when they go to the emergency, they see to it, and then they have to manage the patient.
I request Dr. Madhubala ma'am to please come up and be seated as the chairperson, as sir is not available. Dhiren sir is not.
Thank you, Dr. Madhubala, for joining us as a chairperson. With this, previously we have gone to the bowel anastomosis. Now, if we are not able to do the bowel anastomosis or certain reasons, we have to create the stoma. Stomas are created for the various reasons. What are stomas? These are mainly mouth as an artificial opening in the abdomen wall. There we have got the natural openings like in the nostrils, mouth, anus. But basically, as this CME is for the intestine, that is bowel, breast, and the chest, so I will concentrate myself on the intestinal anastomosis. So, what are the indication of stomas? In the morning session, there was indication for the indication principle, other thing for the intestinal, how to for the making the ileostomy and all. But that session has been postponed for the tomorrow. So I will some insight of what are basic indications. Then we'll proceed further. So stoma can be made for the feeding, for the lavage, for the decompressions, for the diversions, and for the externalization of the some perforate or the infected bowels. So type of intestinal stoma can be classified as for the duration. It can be temporary, it can be permanent. Then as an anatomical location, in the CNS, ventriculoplasty may be there, respiratory tracheostomy, in GIT, allostomy, colostomy, etc. Then, as per reconstructed, it can be end, it can be loop, it can be double barrel, it can be end to side or side to end. Various type of stomas are there. So mainly, basically, intestinal stomas are mainly stoma or ostomy are the two things. When intestinal stomas is there, it is surgically created opening on the abdomen, which allows stool or urine to exit the body. So mainly in the abdomen, we make the three type of stomas. That is alostomy, colostomy, and the urostomy. So also sometimes what we do, we can do the tube cecostomy also, but which is not exactly the alostomy, because we don't externalize anything. We just do the tube cecostomy. So these are various sites. We can do the tube cecostomy. We can do the ascending colostomy. We can do the colostomy, transverse colostomy, descending colostomy, sigmoid colostomy. But basically, what we use bowel, we prefer the bowel which has got the mesentery. So in the ileum, we can take the ileum in the small bowel. In the for the colon, we take the transverse colostomy or the sigmoid colostomy. Also in the urinary stomas, it can be vesicotomy, where we can have to open the urinary bladder. We can have the ureterostomy, where we have to the ureters, and we can make the ileal conduit, connect to the ileal conduit and externalize them. So principle is, we have to anything from the abdomen, we have to brought through the abdominal layers to the outside and to externalize and make the stomas. Mainly in the alostomy, where whatever coming from the from the product, that is the liquid, then we have to make some sprouting so that it goes into the bag, because ultimately they have to be drained into the bag. When it is solid like fawn feces, then we don't have to make a sprouting or nipple shape, and we have to make it externalize and it will go into the bag, so that there should be no decontamination, etc. But this making a ostomy is very much psychological pressure on the patient. Psyche is changed because patient now has got a new opening for passing the urine or the feces. So we have to basically, if we have got the time, we have got the making the elective ostomies, then at least we have to do the psychosocial and the physical preparation of the patient. We have to explain the indication and the complications to the patient. Then we have to take the, if best is that we have got a dedicated nurse which take care of the ostomies for the patient, and if required we can take their opinion. And it is best that we should get the stomas through the rectus abdominis sheath. So criteria consideration for the position of the stoma is that making a stoma shed, patient should able to see the stoma well. It should be 5 centimeter from the umbilicus, in the spino-umbilical line, from all the bony prominences. So all the bony prominences should be away from the ostomies. It should be away from the scar and skin cases. It should away from the bony points of the waistline of the clothes, and should be easily accessible to the patient. That is not under a large fold of fat. So what makes a stoma difficult? It is a poor planning which makes the stoma difficult. If we don't plan the stoma, it is not that you go to the OT, you operate, then you see that now we have to make the stoma, and then you make the stoma. If we don't plan properly, pre-operatively, then it makes us difficult, stoma to be difficult. So poor planning, technical errors, and difficult post-operative maintenance, they make the stoma difficult. These are the, see, this is non-difficult stoma, well-formed stomas, but it has got an imperfect location. So it is not that you have made the well stoma, good stoma, but if its location is not well, then there is an issue. And this, in this patient, if we want to make a stoma, will be always be difficult. So in the preoperative consideration, location, that is must, very important. So we have to see whether this patient really needs this stoma. Is there indication, because you are changing his whole life by making a stoma. Like a single catheterization have the whole life bearing on the patient. So once you are planning the stoma, you have to see really this patient need the stoma or not. Then quality of life issues, whether it will be elective or emergent, emergency done, whether we have time to educate the patient and its attendant for this allostomy, and will this be reversed or it will be permanent allostomy. So how to prepare a site for a stoma? Examine the abdomen with patient clothed, so you can see that where is the belt line of the patient. Then examine exposed abdomen with patient supine, standing, sitting and bending over. Then we have to identify the skin creases, folds, skin problems, scar, bony prominences. We have to draw imaginary line where incision will be so that we could take the ostomy away from the incision line. Then we have to choose 5 cm away from the incision line with 5 to 7 centimeter away from flat surface. We have to identify and mark edges of the rectus muscle. Here, choose an area visible to the patient but below the level of the belt line. We have to mark the site with the X. Then examine mark with patient supine, standing, sitting and bending over. See here, we have mark the patient and lying down, but now when we make the patient sit, it is coming in the skin fold. So this is not a good site for the stoma. So this is the better position. So after marking, we have to mark and cover with the tape, so that in the operation theater, surgeon should know that this is the mark of the tape. Special consideration has to be given in the obese patient, in the patient having the ventral hernia, having multiple stoma, prior stoma, lifestyle of the patient, as well as when we want to make 1 or 2 more stoma in the same go. So in a short video. Here, first we have to mark from the vertical down and the horizontal line. Then we palpate for the bony prominences, that the anterior iliac supraspine, and draw a line, spino-umbilical line. Then we have to ask the patient to cuff. While patient is cuffing, we have to see for the lateral margin of the rectus muscle. We have to see this is the incision line. It should be our mark of the ostomy should be away from the incision line. Then we have to take gap at least 2.5 centimeter, 5 centimeter away from the umbilicus and from the any spinal prominences. So we have to take a best position in the lying down. We have to mark it. Then also we can mark one position above and one position below to that mark, so that we have got the alternative marks in the while patient is lying down. Then after that we ask the patient to sit after marking the points. While sitting, we ask the sitting, then in bending position, we see for that which ostomy site is the best for the patient. After deciding that it doesn't come under the skin fold and it while bend and also it is below the belt line, then we decide that this one will be the best site for the ostomy. We make our final decision and we rub rest of all the marking from the abdomen. Then we take a tape and put that tape on the ostomy site and educate the patient and its attendant that this tape should not be removed till patient is taken up to the OT and in the operation table. Then for the second site, again we ask the patient to cuff to see the rectus abdominis. First we mark. Again, like we mark in the right side, again mark on the left side. So after cuffing, we see for the lateral margin of the rectus abdominis. Then again we draw a line vertically downwards from the umbilicus. Then again one line in midline in the midline. Then again from the symphysis pubic tubercle, from the anterior suprachial spine to the umbilicus. And same here, we put take around 3 fingers. We make a mark, and then one mark above it and one mark below it, so that we have got the alternate sites for the ostomies. We have to take care that it should be away from the umbilicus and it should be away from the bony prominences. Then we ask the patient to sit and we check for the various ostomy sites, and it should become under the belt line and also it should not become under the skin fold. Once you have decided, sometimes what happens, suppose we have to require 2 stomas on the same time. One is for the allostomy and one for the urostomy. So we take one side lower down and one side upper. So if required, we can keep mark 2 sides. site 1 and 2, so that if required on the same side, if as compared to the right side, we can mark 2 sites on the left side, and when required, we can take 1 or 2 sites for our preferences. So this will be our site 1. And similarly, above it, we will take a site 2. And rest we will rub off. And we put the 2 tapes on our 2 decided sites. And we mark it as a 1 and 2, so that in the operation theatre, surgeon should know that this is the marking. So this is how you mark the site for the ostomy. Then we come to the colostomy. As you know, colostomy is an artificial opening made in large bowel to divert feces and flatus to the exterior, where it can be collected in external appliances. Depending on the purpose for which the diversion has been necessary, a colostomy may be, by anatomy it may be transverse colostomy, descending colostomy, or the sigmoid colostomy. By function, it can be decompression or the diversion colostomy. By construction, it can be end, loop, or the double barrel. It can be, indication can be diverticular disease, colorectal disease. It can be appearance, maybe flush with the skin or mucosa suture to the skin. Location can be at the left iliac fossa or the permanent, or the left iliac fossa or the right hypochondrium. It can be temporary. Effluent mainly from the colostomy comes some semi-solid or the solid effluent come from the colostomy. That's how you differentiate from the ileostomy. It comes your examination when your patient is given to you. So you have to differentiate whether this is ileostomy or this is the colostomy. So this you can decide by seeing for the site that it is right iliac fossa, left iliac fossa. Second, whether sprouting or flush with the skin. Third is what effluent coming from the stoma. By this you can decide, because this is the most common cases coming to your examination. So colostomy can be loop colostomy, end colostomy, or a double barrel colostomy. And these are various sites. And in loop colostomy, we can use a rod and immediately suture the bowel mucosa in the skin. So indication can be imperforate anus, Hirschsprung's disease, abdominoperineal dissection of a lower rectum, anal canal tumor, diverticular disease, etc. So these are the same indications. Site can be used in the transverse colon, mainly in the disease where left side of colon disease is there. Then we have to take the in the epigastrium, and the sigmoid colon mainly when we have the rectum or the recto-stomach junction pathology. So how we do, mainly we prefer the GA, because mesentery, when traction is there, it can cause the pain. But nowadays we have got the more and more anesthesia advancement. We can also do in spinal with some sedation and other preferences. A transverse incision is given with removal of this skin. Then after that we cut the adductor sheet. Then after that we go for the either divide or dissect the muscle. Then we pull off the peritoneum, and then after reaching the peritoneum, we take out the colon, whether transverse or the sigmoid colon. And then if transverse colon is there, we have to remove the omentum, get omentum from that, and then we give the incision and do the colostomy. So this is a short video. Okay, so here we are giving the incision. We are dissecting the subcutaneous tissue. Then we are giving the incision over the rectus sheath. We can give transverse incision, or better if required, large bowel, they can give the cruciate incisions in the rectus sheath. Then we dissect the muscle. Below it, we can take under the hemostat, and we cut under the hemostat to reach inside the peritoneum. After reaching inside the peritoneum, we put our finger to see that there is no adhesions in and around the opening and bowel is clear from all the adhesions. Then if available, we can insert a wound protector and get the bowel outside from the abdomen. How can you differentiate whether it is transverse colon or it is the sigmoid colon? We have to differentiate because sigmoid colon may be sometimes so large that it comes at the upper bowel, upper part of the abdomen, and transverse colon may be so large that it can come the lower part of bowel, abdomen. So once we get the colon, we identify the colon by the identify the colon, and then if it has got the greater momentum attached, then it is the transverse colon. If not, then it will be the sigmoid colon. So we put a tube in the colon so that it doesn't go out. Then we are doing the transverse colostomy, so we dissect the colon away from the, dissect the greater momentum away from the colon, from the anti-mesenteric border. Then we again put all the bowel and the mesentery and the momentum again in the abdomen, and we can remove the, if we have put the window protector, we can remove the window protector, wound protector. Then after that, we again pull our colon back. And then if available, we can put the colon rod. Then we have to open the colon, and while opening, we have to take precaution that we have to suck all the effluent coming from the both proximal and the distal side to avoid the soilage of the skin. So we can use the some suction to get all the effluent from the colons. We have to check the patency for both the proximal and the distal colon, and then after that we put the stitches and from the skin to the colon. Firstly, we can put the 12, 6, 3 and 9. Then rest we can put 4 more stitches in between them to fix the colon to the skin. So this how it has been completed, and we have to apply the bag. In double barrel colostomy, the colon is divided so that both the end can be brought separately to the surface with a skin of bridge intervening. Advantage is that it ensures that distal segment is completely defunctioned. As our purpose, distal segment should nothing should go into the distal segment. It is created when where proximal end is the drainage. We apply both the proximal end as the stool drainage and the distal end for the mucus fistula as the mucus drainage. So here you see that double barrel transverse colostomy. Then Hartmann procedure. This includes the proximal end colostomy with a distal closed colonic segments. This procedure can be used when resecting a tumor of the left side of the colon or in the complicated diverticular diseases, or mainly when it is a rectal carcinoma which is non-operable. Then we do the Hartmann procedure. So in Hartmann procedure, we do the end colostomy. This is a picture of the end colostomies. What is the issue in the colostomy is that we should be on the same line for what the patients need. If we make a good colostomy, we make the good surgery for the patient, but we have not up to the patient's need, patient requirement, and not taking the overall functioning of his job to the patient, then it will be good work both the PWD as well as our electric company. But both have then done their good job, but not in the coordination. So we have to be coordinated with all the teams of the patient care. Then comes the allostomy. It is an artificial opening by ileum to the skin of the abdomen, and it is the Brand Brook who has given this stoma surgery and revolutionized in the 1952. So endoscopy is indicated when total protocolectomy is done, like in the ulcerative colitis, Crohn's disease, or the familial polyposis coli. This is short video for the endoscopy. After mainly endoscopy is done after the surgery has been done, and then we have on the selected site we make an incision, remove the skin. It is best thing that we have to get the protection under the abdominal wall where the site of the our alloscopy is there. We give the incision and remove the skin. Skin and subcutaneous tissues are being removed. It's our choice whether we want to give the transverse incision, vertical incision, or cruciate incision. As per Bowel's diameter, we have to give the incision in the rectus sheath. Our main purpose is that whatever bowel will bringing out of the abdomen, it should not be constricted after we are making the stoma. So muscles is dissected, and with the open abdomen we have a we can just get it from the inside. We can get the opening made because it is already protected. So we are there's no much issue. We can dilate the opening by our fingers, and then we can get the segment outside the abdomen either by the fingers or by the Babcock. But while bringing the bowel outside, we have to ensure that it should not be rotated. It should be in the same lie where it is in the abdomen. Otherwise, there can be rotation. It can lead to the obstruction. So it is very important that when you bring the bowel outside, you should see that it should not be rotated. Then we close the abdomen and then we mature the alloscopy. So indication of comes the loop alloscopy, where we make the loop of the ileum. This is a loop alloscopy. Again, techniques is same, but we have to get the loop instead of the end of the bowel. It can be Mikulicz, Bishop, and end to side, side to end, and as well as the tube enteroscopy can be done. In the decompressing examples, these are the very examples which show that it can be end to side, it can be double barrel, it can be any other. So this is a short video for the loop alloscopy. What happens when we have to do the endoscopy? We have to we mainly do after the laparotomies. But loop alloscopy can also be done without opening of the abdomen. So we have to remove the whole of the skin, subcutaneous tissue where we are intending to do the alloscopy. And again, similarly, we have to cut the rectus sheath, dissect the muscle, and bring out the bowel. It is very necessary that we have to check that there is no adhesion in and around the stoma, and also bowel orientation is not being changed, that it should not be rotated. It is very important. Otherwise, later on we will lead to the obstruction and we have to again redo the procedure. So after getting the bowel outside, we open the bowel, and while opening, we suck all the contents effluent coming from, so that there should be no spillage. Difference between allostomy and the colostomy creation is that allostomy, we make something prouted about 5 to 6 centimeter initially, which is later on after months it goes down to the 2 to 3 centimeter. In colostomy, it is not necessary to make it proud, just making the skin flush is necessary. So we have to get a much amount of bowel outside the abdomen wall, especially for the proximal end. Then we start taking the stay sutures from the skin to the wall of the bowel, and first we take on the 12, 6, 3 and 9, and later on we again put the sutures in between them. While taking sutures, we have to take care that if there is any bleeding point appears while we taking the sutures in the serosa and all, has to be controlled. Mesentery should not be damaged, because if it is there, then they can later on keep on bleeding and it can lead to the complications. So strict hemostasis has to be maintained. And if there is bleeding, then it has to be taken care then and there. It should not be that after making stoma we will do it, because once it comes below the edges of the stoma, we can't able to do the take the care of the bleeding. So see how sophisticatedly and delicately we are everting the edges of the bowels to make a proper allostomy. Because sometimes this bowel is infected, edematous, and if we don't take the proper care, it can lead to the damage to the bowel wall. There can be bleeding, there can be serosa damage. So very gently it has to be handled. So this is how it will be created, and we keep the proximal one more prominent as compared to the distal one, so that whatever effluent coming, it drops into the bag. Then comes the cecostomy. Indication is trauma to the cecum, having the closed loop syndrome, and mainly we make in the right iliac fossa. Uretrostomy mainly surgical diversion of the urinary system, done for the bladder carcinoma, urine incontinence, neuropathic bladders. And formation of uretrostomy, either if sometimes we can do the directly get the ureters outside the abdomen. We can do make the iliac conduit, and that there will be it comes to the outside the abdomen, or we can do the ureter maybe implanted into the sigmoid, that is sigmoidourethrostomy, and then urine will come through the feces from the anal canal. So for the appropriate length for stoma in allostomy, total bowel length above the skin should be 6 to 8 centimeter. loop of 3 centimeter at the mesenteric apex. Height of the spout after alostomy creation should be 20 millimeter, because more than 20 millimeter, because it decreases with the skin and the wound issues. Colostomy total bowel length should be 2 to 4 centimeter above the skin. Height of stoma after colostomy measurement should be done for more than 5 millimeter. So ostomy should have a bag in place. Depending on location, ostomy may produce liquid or solid fecal matter. Digestive enzymes may corrode the skin around the stoma. So ostomy site should be pink or red. Most pouches can be emptied without the removal. So these are the various pouches and bags available, and which is also the topic for the panel discussion. So I will not discuss it much, and will not take the much discussion here for the how to put and what are the complications for the ostomy, how to take care. That will be discussed further in the presentations. So problem. What problems can occur while making the ostomies? Difficult situation may be an elderly patient or 60-year-old male, 60-year-old man or female having the elderly, and then there may be issues. Then patient may be diabetic with having the chronic heart failure. Still we can manage. Then some comes with the perforated diverticulitis. Why it is important? Because perforated diverticulitis, already there is so much inflammation in the abdomen that is very difficult to dissect the bowel, get the bowel for the your ostomies. Then comes the, sometimes we have got the 2, 3, 4, 5 laparotomies. Already patient undergone, and patient we have to make the ostomies. And above this all, if patient comes with the septic with the peritonitis. So all this creates a difficult situation. So stoma creation can be very easy and can be very difficult in the case of scenario. Especially in the, because this mostly stomas are created in the emergency scenarios where residents, senior residents are there and they have to make it. Sometimes when this difficult situation arises, so you have to see that this, these are the conditions where difficulty can arise, and also, then you can also apprise your consultant that if required, we can have to take your help. So it is difficult to make a stoma in the inflamed, thickened and the foreshortened mesentery due to the prior operations and the inflammatory changes, due to obesity where thick abdominal wall and poor tissue quality is there, and the distended colon. How will you deal with the stoma creation in the obesity? Mostly patient comes to us in our scenario in medical colleges. Mainly comes patient are obese. Many they come when having the perforation, peritonitis and other reasons. But in some cases, some scenario we also have the patient which are obese. Then why it is important? Because increased depth of skin cases cause pouching difficulties. Even in properly constructed, well located ostomies, there is difficulty to make the ostomies. It is difficult to identify the rectus muscle preoperatively. So what we can do if it is difficult? We can take the help of the ultrasound. We can mark the before surgery. We can mark the boundaries of rectus abdominis by the ultrasound, and we take the help of ostomy system nurse to mark the site. Then obese patient cannot see their lower abdomen, so they can't take care of their ostomies. Thicker abdominal wall adipose tissue requires increased amount of length of the mobilization. So again, we have to get the more bowel for the making the ostomies. So what to do? We have to, in these obese patients, we have to, instead of planning here in the lower abdomen, we have to go up to the north and have to make the ostomies more upper part of the abdomen instead of lower part or the abdomen. Then after making ostomies, it is very important for the psychosocial and the vocational implications. We just make the ostomies and then leave the patient and just take care of the ostomies. No, we have to take whole of the patient for the ostomies, because they have got the occupation, they have got the psychosocial bearing. All this has to be taken in the view. So ostomy surgery does not, so where there is change in the body image, ostomy surgery doesn't have any implication on the vocational functioning. They can perfectly well do their work. There is some change in the body image which patient feels, so we have to counsel him. Economic cost of living with the ostomy can be considerable when complication from the stoma or disease process develops. So we have to also educate him so that he take full and proper care of their ostomies. and we have to provide information, education to the person along with his attendants in the manner that relays a message of the acceptance, so that they accept it, and if any complication arises, they can manage it. So, in summary, it may be allostomy or the colostomy, it may be temporary, permanent, it may be due to dysfunction, but allostomy effluent is mostly liquid and they develop the mainly complications. So, we have to see for the allostomy sites, we have to see for the end colostomies where it has to be made. We have to try that if required, then only ostomies should be made. If not, then at least it should be temporary, and only when in the drastic cases we are required for the permanent ostomies. So, in the what is better, endostomies or loop ostomies? Endostomies has the feature that it is vascularly compromised as compared to the loop ostomy, but has more and also have the more chances of stomal necrosis. But it is easy to fix, appliances are easy to fix and has a less leak rate, but reversal is difficult. So, if we have the choice for the endostomy and the loop ostomy, we should prefer for the loop ostomy, because if we require the closure, then it can be done from the without doing the re-laparotomy. We can just close from the local site. So, it is to always remember that pre-operative planning, operative technique, pre-operative education are the vital of importance, and make every stoma as though it was going to be permanent. So, as Peter Kettledore said, better to create an ugly stoma in a good location than a pretty stoma in an ugly location. Any questions? Thank you so much.
In a transverse colostomy, you prefer to open the colon on tinea, or you want to cut transversely? Some people say 3/5 of the circumference should be divided. Some people say you open on tinea so that the bleeding is lesser at that point. And secondly, in ileostomy, to make it more proud so that it well fitted, you take a suture in a way that it passes through the skin, then the seromuscular suture through the wall of the intestine, and then mucosa, so that it can protrude out well like a nipple.
Thank you, sir. Very good questions for the PGs. And transverse colostomy, we don't consider just we can give the incision because it has to be flushed. So we have to make no nipple-like shape for the colostomies. But in allostomy, we prefer that it should be 2/3, 1/3, so that proximal end should be having the nipple appearance and the distal end can be having the flush with the skin. Incision we prefer transfer, we give the transfer incision so that it should be given the longitudinal incision. Sometimes what happens, there is a problem, it can tear further. So we give the transfer incision, but it's depend on the preference of the surgeons. It is not any hard and fast rule. And we give the transfer incision, and after giving, we fix the pull.
I think Dr. Nivesh has made very much clear, and the take-home message for every young surgeon is, you must divide the bowel in a transverse fashion, maybe a ileostomy, maybe a colostomy. That will serve a very simple purpose, that it will divert the feces from not going from the proximal to the distal segment. That is the one advantage you will get once you divide transversely. Almost 2/3, 1/3 or 3/5 or 1/5, you may do like that, 3/5 and 2/5 of that, so that the proximal stoma will come out. The effluent from the proximal one will come out, will not enter into the distal, which will be a chance once you are dividing along the long axis of the bowel. That is the problem. And Dr. Nivesh has emphasized a very simple thing, always and always put in a bridge, maybe infant feeding tube or maybe a thing. By that, many of the complications will not be there. Previously, traditional ones, we used to fix it by the fascia with the peritoneum. That is not required. You only fix it with the skin, but after putting in a bridge. That is very important.
Thank you, sir. Thank you so much.
Thank you, Nivesh sir. You have covered topic very nicely. Especially the videos made the talk interesting and not boring. Thank you.
Thank you. With permission of chair, I can. Thank you.
Thank you, sir, for such a wonderful, wonderful session. I would like to invite Dr. Madhubala ma'am and Vipin sir to felicitate Dr. Nivesh Agarwal sir.
Thank you, sir. Now I request Dr. Sanjay Pandey, sir, and Dr. Ashok Sharma, sir, to kindly facilitate Madhubala, ma'am, and Vipin, sir. After this informative session, let's head towards our next informative session, that is on the topic stoma complication management and care. For it, I call forward the panelist, our esteemed panelist for the panel discussion, Dr. Bhaskar Kumar sir, who is currently working as Associate Professor in Department of Surgery at GS Medical College, Pilakwa, Hapur. Dr. Ashok Sharma sir, Professor and Consultant at VMMC and Safdarganj Hospital, New Delhi. And Dr. Rajat Piplani sir, Pediatric Surgeon by profession and currently working in AIIMS Rishikesh. We are honored to have you all here, sir.
On the behalf of moderator Dr. Madhubala ma'am, I would like to invite her on stage, who is a dynamic surgeon and is currently working as HOD and AMS in GS Medical College, Pilakwa, Hapur.
ऐसे ही लेना thank you very much, Dr. Anurag Srivastav sir, Maheshwari sir, Sanjay Pandey sir, Dr. Shashank Mishra sir, Dr. Krishnamurthy and organizing secretary Dr. Aditya for giving me this opportunity. So today's topic I welcome all panelists. Today's topic for panel discussion is stoma complication management and care. I am going to discuss mainly complications of intestinal stomas, that is colostomy and ileostomy. So these complications, they are divided as early, which are occurring less than 1 month, and late, occurring more than 1 month. In early complications, there are mainly complications related to skin, stomal necrosis, bowel obstruction, ileostomy diarrhea, mucocutaneous separation, stomal retraction, and stomal prolapse. Stomal prolapse rarely occurs as an early complication, mainly it is late complication. And in late complications, again there are skin complications, stomal stenosis, stomal prolapse, parastomal hernia, and fistula. Metabolic complications, these are late, and they are cholelithiasis, urolithiasis, and vitamin deficiencies like B12 and folic acid. So let us discuss all complications one by one. Complications related to skin are dermatitis due to chronic irritation and wetness, allergic dermatitis, peristomal pyoderma gangrenosum, peristomal ulceration, granulomas, portal systemic venous communications, infections like folliculitis and skin abscess. So in dermatitis, it can be due to irritation and wetness. Most common complication, and it is more common with ileostomies, because of this higher liquid content, that is passage of chronic stool leakage. Mostly occurs in poorly seated stoma, non-nipple ileostomies, poorly fitting appliances, and high output stoma, so common in ileostomy than colostomy. There is peristomal rash with satellite lesions, may be associated with fungal infection. In management, we usually use sucralfate powder, antifungal powder, and antiperspirants known as silver paints or Coloplast. Properly fitting appliances solve most of the cases in skin irritation or rash. Then come to allergic dermatitis. Peculiarity of this is that it occurs at the onset of use of new appliances and only occurs in areas in direct contact with the appliances. Changing the type or brand of the appliances and application of topical steroid agent results in complete resolution. Testing the reactivity of various types of skin barriers before stoma reconstruction minimizes the chance of allergic dermatitis. Next complication is peristomal pyoderma gangrenosum. It is an inflammatory skin disease characterized by rapidly growing painful ulcer with purple edges developing around the stoma. Pyoderma gangrenosum is associated with inflammatory bowel disease, particularly ulcerative colitis, and it is most common after resiting or refashioning of the stoma. Unroofing of the ulcer, trimming overhanging edges, giving intralesional corticosteroid is helpful, and there is sustained response rate of 80% with infliximab therapy, and especially in patients who have failed first-line therapy. Ultimately, patients require resiting of the stoma, which is successful in 87% of the patients. Peristomal ulceration, it can be traumatic or due to leakage. There may be pressure from an ill-fitting stoma device or leaking of alkaline stool results in maceration, which ultimately results in superficial ulcers with sloping edges. Successful management depends on correction of the pouching and treating the ulcer with silicone-based film or hydrocolloid powder. Infections include folliculitis, which is inflammation of the cutaneous hair follicles. Folliculitis can occur due to trauma while removing the appliances or while shaving or clipping of the hair. It is rarely infectious and very rarely requires antibiotic course. And mild folliculitis clears within 7 to 10 days with gentle pouching technique. Peristomal abscess, herald, and underlying fistula tract opening. Gentle ileoscopy demonstrates active Crohn's disease and will guide the management. Basic principle of treatment include control of cystis and treatment of underlying bowel disease. The development of fistula early in the post-operative period is likely to be related to a missed serosal tear or enterotomy. In immunocompromised or diabetic patient, peristomal sepsis can quickly get out of control, which leads to severe cellulitis and ultimately necrotizing fasciitis. Early ileostomy fistula are high fistula and they will not heal with conservative management. It is best to do local revision of ileostomy. Colostomy fistula can be treated conservatively and fistulotomy can be performed under local anesthesia. An unmotivated patient or failure to heal within 2 weeks is an indication to revise the colostomy in operating room. Skin granulomas, it is late complication. Small granulomas develop at mucocutaneous junction, usually from excessive friction around the stoma, retained suture, and Crohn's disease. This can be unsightly for the patient and sometimes cause small amount of bleeding. The primary treatment is repeated application of silver nitrate until the lesion has disappeared, and rarely surgical excision is done under local anesthesia. This is the last skin complication, portal systemic venous communication at the site of stoma. It is again a late complication. Patients with portal hypertension develop portal systemic venous communication around the stoma, and it gives rise to so-called caput medusae appearance of dilated veins around the stoma site. These veins can present with intractable stoma hemorrhage from even after minor traumas such as removing or inserting the stoma bag. Causes are portal hypertension due to primary sclerosing cholangitis or alcoholic cirrhosis. Incidence is up to 27% in patients with hepatic dysfunction. Management should be to stabilize the patient, control of bleeding, correct any coagulation deficiencies, direct pressure and adrenaline injection, suture ligation at the hemorrhage point, mucocutaneous disconnection, cauterization of stoma, transposition of the stoma, portosystemic shunts, and liver transplantation. Mortality is high and depends on severity of the underlying disease. A well-placed suture at the exact point of hemorrhage may help. Some authors advocate local surgery where the stoma is mobilized at the mucocutaneous junction and the variceal identifier are ligated. This stomal disconnection can be very bloody and it is more difficult than it seems, and the venous connection re-establish themselves quite quickly. A more permanent solution is to treat the underlying cause of increased venous portal pressure. I have finished the skin complications, and now my first question is to our first panelist, Dr. Bhaskar. What advice you will give to patient while doing stoma care, while taking stoma care, like putting the appliances to avoid the skin complications?
First and foremost, the skin around the stoma should not be rubbed. It should be pad dry, and the skin appliances like the skin barrier should be applied, and the proper size of the ileostomy bag should be made before applying it, so to prevent the skin excoriation and the complication. And the bag should be emptied as 1/3 of the bag is full, then it should be emptied, or every 4 to 6 hourly, so to prevent the skin excoriation.
So most important instruction given to patient is there should not be any overfilling of the bag, very important, because due to pressure there can be leakage of the content. So once the bag is 1/3 filled, it should be emptied. My next question is to our second panelist, Dr. Ashok Kumar sir. Sir, would you like to add any more complications?
On stoma necrosis.
Yes, sir. In skin complications.
Skin in stoma necrosis, most important is that doctor said there is a chance. Don't rub the skin area. Only just wipe the skin with. There is no use of hard septic solutions or like hard chemical agents. Just rub the mild soap and put the dry. It consists of so many antimicrobial agent. Don't use any antimicrobial agent.
Thank you, sir. My next question is to Dr. Rajat. He is pediatric surgeon. Sir, what is your opinion about the skin complications in pediatric surgeon in relation to incidence and skin care and management? Is it different from adult?
See, most common complication involving the skin in stoma is skin excoriation, and this skin excoriation is secondary to the effluent which is coming out, and it is avoidable. And in most of our pediatric patients, we generally don't put stoma bags so early because we don't have a much space there to put a stoma bag. So we ask them to take care by local means. We just apply coconut oil and a zinc oxide paste over it, because coloplast is also not fitted, it's not very good for these pediatric patients. So generally we ask them to manage the stoma like that only, and we don't apply bags so often. Bags are applied in a younger child or an older child, but not in neonates or an infant. So skin excoriation is the most common, followed by other complications like stomal necrosis and stromal prolapse.
Thank you, Dr. Rajat. So take-home message to avoid skin complications in stoma patient is good stoma at good site with properly fitting appliances and frequent emptying of the stoma bag. Now let's move to other complications. Stoma necrosis. It is 1 to 5% of patient undergoing ileostomy, higher incidence with colostomy, more commonly seen after emergency surgery and obese patient. Most often noticed within 24 hours post-operatively. Causes are excessive tension over mesentery, short mesentery, obesity, stripping of mesentery due to division of sigmoidal arteries leading to progression of mesenteric ischemia. Examination is done by test tube test to diagnose the level of the necrosis. Lubricated small test tube is inserted into the stoma and flashlight is thrown along the sides of the test tubes, which will help you to examine the inside mucosa. Management of necrosis. At the level of fascia, there is conservative management. This limited necrosis can lead to flush, retracted and stenotic stoma and mucocutaneous separation, which needs revision of the stoma. Necrosis below fascia is managed by immediate laparotomy and stomal reconstruction. So here my question to panelists, Dr. Rajat, is why stoma necrosis has higher incidence with colostomy?
See, the incidence reported in ileostomy is 1 to 5%, you have correctly highlighted. And in colostomies, it is around 1 to 10%. So, to my opinion, as colostomy is more, as a loop ileostomy is more in favor of having good blood supply, and more common is in colostomies is either an end colostomy or a loop colostomy. So end colostomy has a precarious blood supply and more commonly done, and then followed by loop colostomy or a loop ileostomy. So incidence is a little bit higher in colostomies. The second thing is the colostomy site, whether we are doing at the watershed area, either at the rectosigmoid junction, a Sudex point or a Griffiths point. So this is my opinion. I think general surgeons can better answer this.
Thank you, Dr. Rajat. So next complication is bowel obstruction. It is relatively common. Incidence is around 20%. And again, causes are same as in other bowel obstructions like adhesions, internal hernia, recurrent Crohn disease, stomal stenosis, intraluminal impacted full bolus just below the facial level. The clinical features are cessation of stoma output. Sometimes there may increase in partial obstruction, crampy pain in abdomen, vomiting, dehydration. And management is same as in bowel obstruction, like resuscitation of the patient, fluid electrolyte management, nasogastric suction and close observation. If there is ileostomy blockage, pass 24 number of Foley's catheter with 3 ml in balloon, irrigate with 50 ml normal saline. If there is clean return, suspect proximal obstruction and go for water soluble contrast study. If food particles are there, then suspect food blockage. Continue irrigation with warm saline until the function of the stoma returns. So in bowel obstruction, patient can be observed for 24 to 48 hours to take the decision of the surgery, and surgical intervention is done only when pain persists despite of nasogastric tube decompression and lavage, increasing pain, distension, leukocytosis and fever. Mainly reoperation is required in patients with inflammatory bowel disease and colorectal neoplasms. 2/3 of obstruction are related to adhesions and 1/3 are related to stoma. So my question is to Ashok sir, would you like to add on or highlight something about bowel obstruction in stoma?
Bowel obstruction is not so much common if there is tissue handling and bowel. If there is no stoma is tight or there is stoma is perfect, rectus is appearance is adequate, there is least chance of the obstruction. But in case of obstruction, first we observe the patient by conservative management, and if it is not possible, we go for the revision of the list.
Thank you, sir. Mucocutaneous separation. Causes of mucocutaneous separation are tension due to skin opening too large for exteriorized bowel, malnutrition and high dose of steroids. Good enterostomy therapist nursing is important. Packing of subcutaneous tissue with paste material absorptive powder until a new junction forms secondarily, and late consequences are stenosis at the skin level. Now this is very important complication, ileostomy diarrhea. Etiology is excessive enterotomy, sudden discontinuation of steroids and opiates, Crohn's disease, dietary factors, lactose intolerance, intra-abdominal sepsis, partial intestinal obstruction, bacterial, viral or radiation enteritis, intestinal ischemia, stress or anxiety, which occurs mainly looking at stoma site, bacterial overgrowth. Anatomical causes, it is also related to increased body mass. In physiological college, lack of YY peptides, especially in short bowel syndrome. Emotional stress due to looking at stoma site, and methicillin resistant staph aureus, which resides in nasopharynx. This is mainly due to occurs in patients on prolonged antibiotic and nasogastric decompression. Clinical features are excessive ileostomy output. Emptying of the pouch is more than 8 times per day. There is pouch leakage which results in skin irritation, lightheadedness and fatigue. Management of ileostomy diarrhea is mainly electrolyte and hydration management. Apply drainage bag properly and antidiarrheal agents, loperamide, codeine and hisabul. So my question is to our panelist, Dr. Ashok Kumar sir. Sir, how do you manage stoma diarrhea in your institute?
There is stoma or diarrhea is due to the initially due to the adaptation phase of the ileum or adaptation phase of the GI tract. Initially it subsides spontaneously with management of you said like electrolyte and hydration, and after that we are managing like that. If there is ileostomy in initial phase, we go for the electrolyte imbalance or check for the what are the output and give her a second drug, that is the loperamide. You can use the loperamide for.
Thank you, sir. Dr. Rajar, is there any difference in management in pediatric patient?
See, ileostomy is a high output fistula, and in a high output fistula, we generally avoid in a pediatric patients. In some conditions, we cannot avoid. Sometimes it's meconium ileus or ileal atresia. Then we have to manage the child on TPN, total parenteral nutrition. That is our main goal till the child increase in weight and is able to take orally with the fistula content decreases over some time, and it takes a lot of to manage a child, and generally the pediatrician or neonatologist is taking care of the child at that time.
Thank you, Dr. Rajat. So next complication is stoma retraction. Stoma may appear flush or below skin level, and it may result in leakage, soring of the skin and skin excoriation. Causes are obesity, weight gain after creation of the stoma, early removal of the stoma rod, stoma placement in skin fold, and short mesentery for construction of the stoma. Stoma retraction can be intermittent, which is positional. In upright position, stoma length and protrusion are satisfactory, while in supine position, abdominal muscles are relaxed, stoma become flush with skin or may recede below the skin level, leading to soiling, leakage, and difficulty in maintaining satisfactory appliance seal. Stoma retraction management includes skilled enterostomy therapist nursing. Convex face plate placed firmly against the skin sometimes maintains a satisfactory seal. Weight reduction, persistence, leakage, and soiling is indication for revision ileostomy. So in ileostomy revision, circumferential incision around the stoma is taken, and stoma is mobilized to fascia and peritoneum, and tip is resected. Ileum is fixed to fascia. Newbrook maturation can be done. Now come to late complications. These complications usually occur 1 month after the creation of the stoma, and this includes stomal stenosis, where there is narrowing at skin or facial level. Typical ribbon stools are seen in colostomy. Causes of stomal stenosis are ischemia, small opening in the skin or fascia, radiotherapy, Crohn's disease, reaction to suture material. Initial management includes gentle dilatation, low fiber diet, stool softeners for colostomy. Recurrent obstructive episodes or pain is an indication for revision of stoma. In skin level stenosis, detach the skin from the mucosa, excise a small amount of skin to increase the tryphin size. So multiple skin incisions are made outside the ostomy appliances to release the skin stenosis. And fascia is split with scissor. So next complication is stoma prolapse. Incidence is 11% and 13 years, and overall incidence is 1 to 16%. Here stoma increases in size and length, and higher incidence with loop stomas, especially transverse loop colostomies. Bleeds and easily traumatized. In children, colostomy for anorectal malformation and Hirschsprung's disease, there is incidence 8.1% to 58%. My question to our panelist, Dr. Rajat, is why there is high incidence with loop stomas, especially transverse loop colostomies?
See, loop stomas have a redundant distal ileum or a colon. So this redundant colon, generally distal part of the stoma, it collapses. So that is the main reason that it is redundant, and it comes out easily if it's not done properly.
Thank you, Dr. Rajat. Ashok sir, would you like to add some point?
Stoma prolapse in adult also, there is the most common chance of the stoma prolapse because of the long mesentery and bowel long length. But it you should try about the reduction of the stoma prolapse.
Thank you, sir. So these are the various incidences in abdominal pressure. Presentation is enlarged stoma, dislodgement of appliances, bowel obstruction, and pain due to engorgement and constriction of prolapse segment. Less than 10% are complicated by incarceration and strangulation. There is a reduction of acute prolapse is done in supine position. Apply sugar to reduce edema and reduce with gentle rocking motion. In surgical treatment, resection is done. Mucocutaneous dysfunction and eversion of prolapse segment, resection of exteriorized bowel, and recreation of the stoma is done. The most interesting complication is parastomal hernia. Incisional hernia, it is nothing but incisional hernia related to abdominal wall stoma because there is already a hole there. Incidence is 2 to 28% in N colostomy, ileostomy, and 4 to 48% in N colostomy. So there is famous quote, it doesn't matter if God himself made your ostomy, if you have it long enough, you have a 100% risk of parastomal hernia. So this is a parastomal hernia. Bowel protrudes herniates through facial defect. Types of parastomal hernia are true parastomal hernia, where bowel protrudes through facial defect, subcutaneous prolapse or pseudo hernia. Facial ring is intact and the stoma bowel, it protrudes in subcutaneous plane, giving a feeling of pseudo hernia. Then in intrastomal hernia, again there is small facial defect, but bowel protrudes underneath the stoma portion of the bowel. And pseudo hernia, there is weakness of abdominal wall without facial defect. So risk factors for parastomal hernia: waist circumference over 100 centimeter, smoking, older age, malnutrition, and technical aspects involved are it is less common in if stoma is created to rectus. Pre-op sighting is very important. Aperture size more than 2 to 3 fingers or centimeter. Again, there are more chances of parastomal hernia. In stoma created in emergency, again there are more chances. Disease processes like obesity, diabetes, inflammatory bowel disease, COPD, intra-abdominal hypertension, post-op sepsis, perioperative steroid use, malignancy and ascites, all these are risk factors for parastomal hernia. Mainly it is asymptomatic and only 30% of patients required surgical intervention. There is parastomal discomfort with intermittent obstructive episodes. Stroma appliances issues with leak and skin irritation. There can be obstruction and strangulation like in other hernias. Physical examination with a finger in stoma is done and it is necessary to diagnose and characterize the site. Abdominal CT scan is helpful in case of difficult diagnosis. 30% require repair and indications are pain, obstruction, difficulty in maintaining appliances. Surgical management includes local aponeurotic repair, open repair with mesh, laparoscopic repair, and relocation of the stoma. So local repair, aponeurotic repair is done. There is primary closure of defect and recurrence chances are 50 to 76%. So this local repair, it is preferred only in case of very old patients, short life expectancy, and critically ill patients. Now come to open mesh repair. Sublay mesh is proposed as the most advantageous technique for the mesh repair of parastomal hernia. Low weight polypropylene meshes are used and they have better resistance to infection. they have to place away from the bowel, and recurrence rates are 7 to 40%. So these are various sites for mesh placement. Onlay mesh, where mesh is placed anterior to the anterior rectus aponeurosis. In inlay mesh, it is placed in the anterior abdominal wall defect and sutured to the wound edge. In sublay mesh, it is placed dorsal to the rectus muscle and anterior to the posterior rectus sheath. And intraperitoneal onlay mesh, it is placed on peritoneum and within the abdominal cavity. Laparoscopic surgery can be done IPOM, that is intraperitoneal onlay mesh. PTFE mesh is most commonly used, where inner non-reactive layer for bowel contract, and it is more prone to infection. Laparoscopic approach technical tips are: fashion the mesh before insertion in the abdomen with a circular defect and a slit. A good way to reduce recurrence is to place 2 pieces of mesh, one on the top of the other. So this is the IPOM technique, showing creation of slit and a hole and overlapping of the mesh. There is keyhole technique, where we create a keyhole and a slit, and there is another technique is sugar baker technique. In sugar baker technique, mesh is fixed on all sides except one side at laterally, through which we allow entry of the bowel. Tunnel is made, and the stoma entry or tunnel for the stoma is made. In a laparoscopic approach, recurrence rates vary between 4 to 40%, and there are high risk of bowel injury and high risk of mesh infection. So these are various studies showing laparoscopic IPOM versus sugar baker technique. My question is to our panelist, Dr. Ashok Kumar sir. So what is your opinion? Which technique is better, laparoscopic or open, and keyhole or sugar baker?
Basically, laparoscopic IPOM is better if surgeon is able to do it very nicely. And sugar baker technique, thus just you are saying there's the closure of the defect and the lateralization of the bowel, and you can place the mesh. But there is also a new modified technique, modified sugar baker technique. That is better than, because one of the most important is sandwich technique. If you do slit and modified baker techniques, it is better than the laparoscopic IPOM. And I think if surgeon is able to do, laparoscopic IPOM is better.
Thank you, sir. So studies are scant and low powered about the use of bioprosthetics and with short follow-up. Most advantages are extrapolated from the use of bioprosthetics for incisional hernia, and most studies show low incidence of complication and equivalent incidence of recurrence. Recurrent rates vary between 9 to 27% depending on the studies and the type of mesh used, human dermis versus porcine small bowel submucosa. So what is your opinion, Ashok sir, for prophylactic use of mesh at the time of stoma creation to prevent the parastomal hernia?
I don't think there is a prophylactic rule of the mesh, but it is naturally better than the no mesh. If there is no mesh, it is better than the mesh. But it depends on the surgical technique. If stoma creation is good enough, there is no chance of recurrence. But if you can place the mesh, it is better than this.
Thank you, sir. Next is relocation of the stoma. Risk of recurrence at least as high as the primary site. Recurrence rates are 24 to 86% and higher if relocated on the same site. Primary site should be treated as an incisional hernia and repaired with mesh placement. And one can relocate the stoma site on the same side if adequate rectus sheath is available. Otherwise, relocation is done on contralateral side. So, prevention of parastomal hernia. Stomal reinforcement can be done using biological mesh or polypropylene mesh, or biological tissue like tissue matrix can be used. So, these are various studies showing describing parastomal hernia prophylaxis by mesh placement. So conclusion is parastomal hernia, very common condition, and only small proportion, 30% will require surgical intervention. High rate underline the fact that there is no perfect operation for this condition. Promising results are with laparoscopy and bioprosthetics. Prophylactic mesh placement seems to be the way to go. So next complication is fistula. This is a serious problem. Superficial fistulas due to stitch abscess, trauma, Crohn's disease indicate recurrence disease, and they can heal spontaneously. Major fistula below the skin level requires surgical intervention. Now come to metabolic complications. These complications are late and includes cholelithiasis, urolithiasis, and vitamin deficiencies. So in cholelithiasis, there is increased incidence when greater than 10 centimeter of ileum has been resected. 10% incidence is 10% after 5 years of the stoma creation, 25% after 15 years, and more than 50% after 15 years of the stoma creation. Pathogenesis includes increased loss of bile salts and reduction in the bile salt pool, which in turn decreases the solubility of the cholesterol. Patients with ileal Crohn's disease who have 5 to 7-fold increased incidence than normal population. And also deoxycholic acid has a therapeutic role which desaturates the cholesterol in bile. Urolithiasis. Interestingly, there is high incidence of uric acid stones in ileostomy patients. It is 7% when there is no loss of bowel, and 15% when there is 20 to 30 centimeter segment is resected. In some studies, there is higher incidence up to 60%. High uric acid levels in serum contributes to this type of stone formation. Persistent acid urine precipitate uric acid crystals, which in turn results in calcium deposition. So typically in urolithiasis, in ileostomy patients, these stones are radiopaque rather than in other patients where they are radiolucent. Allopurinol therapy helps. In summary, there are many causes of urolithiasis in ileostomy patients. However, an important variable is dehydration with decreased urine output, which is more common in warm climates. Vitamin B12 deficiencies and folic acid deficiencies, they are usually normal in ileostomy patients even when 30 to 40 centimeter of terminal ileum is removed. Additionally, both serum and red blood cell levels of folates remain normal, except in patients with Crohn's disease with ileostomies where these deficiencies are more common. So this is care we have to take, already discussed by Nivesh sir. We have to take care while creating stoma in such obese patient to avoid complications. So tip for success are avoid a stoma if at all, if possible. Excise all inflamed sigmoid colon. Segment used for stoma must be free of inflammation. So this everything has already discussed by Nivesh sir. For bigger hole, expand the facial aperture or skin edge and remove the subcutaneous tissue. For smaller colon, remove excess fatty tissue, epiploic appendages. Trim mesentery, leave 1 centimeter of mesentery on distal bowel to preserve marginal artery. Decompress the distended bowel. Pseudoloop is created only in emergencies, only when there is no other stoma will reach. Remember, always go north in obese patient because patient can see it. So these are tips and tricks to prevent stoma complication. Site of the planned stoma should be carefully selected preoperatively. Surgeon or enterostomal therapist should be marked stomal site with patient in lying, standing and sitting position. In sitting position, there are maximum creases, so we can avoid stoma at the crease line. It should be situated to exit through the rectus abdominis below the umbilicus, taking into account the constraint of wearing pants. Should allow the patient to see his stoma. Ideally, it should be located at the intersection of the bisectors of triangle composed by the umbilicus, the anterior superior iliac spine and the pubis. The video was shown by Nivesh sir. So avoid stoma at skin crease. This everything was already discussed by sir. Some benign complications that require patient education, an event that may be cause for concern and unnecessary consultation is continued passage of stool by anus despite the presence of a stoma. This can be temporary or permanent. This phenomena is explained by the presence of residual stool in the downstream colon, by incomplete diversion of a loop colostomy, or by colonic secretion of mucus, that is Vitti stool. And this must be explained to the patient before discharge. The anatomy of the stoma must be discussed with patient. So in stoma care is very important to avoid the complication. So basic counseling of the patient is very important by giving information regarding the basic stoma function, proper selection of pouching system, attainment of secure, reliable and odor-proof pouch, how to use stoma appliances, instruction for pouch emptying, skin care, self-care, and quality of life is very important. Here is a role of psychotherapist, because 1/3 patients suffer from depression, social problems, sexual problem. They are very conscious about their body image. There is role of enterostomal therapies and wound ostomy continence nursing practice. Nutrition, fluid electrolyte management is very important to avoid stoma diarrhea. Remember, preoperative planning, operative technique, postoperative education are of vital importance, and ounce of prevention is worth of a pound of cure. Make every stoma as though it is going to be permanent. High incidence of complication, early recognition and management is desirable. Patient education and involvement of enterostomal therapist is essential. So this is life beyond stoma. It is multidisciplinary approach. By taking stoma care, one can maintain their social and professional life if they take proper care. Thank you very much.
Thank you, madam.
Would you like to add something?
Yes, for the postgraduates, I would like to mention that stomal complications are avoidable. If properly done, stoma, the technique should be very sound. Firstly, we have to take care of the feeding vessels. Feeding vessels, there should not be any tension on the vessels which we are removing the stoma outside the abdomen. The vessels should not be under tension, one. The other thing is the facial defect which we are making, or a skin incision we are making, should be appropriate, so that it should not go into a stenosis or a retraction afterwards, or a stomal necrosis. Thirdly, the dissection around the mesenteric vessels, parastomal mesentery, should be minimal. So these all things should be taken care, and the stomal complications will it will reduce your stomal complications in your patients.
Thank you again.
Would you like to add anything?
Thank you again, all our panelists, Dr. Ashok sir, Dr. Rajat, Dr. Bhaskar, and audience for listening patiently. Thank you.
Thank you, madam.
What can be done for the prevention of prolapse after the stoma? What we, at the time of surgery, what precaution we should have so that in future the prolapse will not occur? The mucosa will come inside out.
First, we make a slit, like not so defect in the rectus sheath or rectus muscle. That is important. Size of the colon or size of the ileum is appropriate to the stomal opening. First we make. And suture line, it is not fixed like surgeon says, it is not fixed with the skin only. If you can see fixed with rectus sheath also, there is no prolapse, chance of prolapse.
Thank you.
Hello. Thank you, sir. Now I request Madhubala ma'am to please felicitate our panelist, Dr. Rajat Piplani, sir. Now, Dr. Ashok Sharma, sir. And now Dr. Bhaskar Kumar, sir. Thank you, ma'am. Now I request Dr. M.K. Maheshwari, sir, to please come and felicitate Dr. Madhubala, ma'am, for this wonderful session.
Thank you, ma'am, for enlightening us with such a knowledgeable topic. Heading towards the next talk on the topic esophageal and gastric anastomosis, we would like to call on stage our robust speaker, Dr. Devendra Singh, sir, who is professor at AIIMS, New Delhi, and who has many accolades in his name. Sir, we are honored by your presence.
बुला लीजिए आप स्क्रीन पे आ गए.
Coming to the chairpersons for the talk, we take this opportunity to call on stage our very own Dr. M.K. Maheshwari, sir, who is professor in Department of General Surgery, Subharti Medical College, and has been a continuous inspiration force for his students for many years. So please be seated on stage.
I would also like to invite a well-known name, the medical fraternity of Meerut, our very own Dr. Sanjay Pandey, sir, who has been an amazing mentor and has shaped lives of many future surgeons.
So good afternoon, namaskar. I request the students sitting at the back, please come forward. I am standing between the lunch and you, so don't worry, I will complete my presentation within time, or please give me 20 to 25 minutes. So good afternoon, respected chairpersons, senior faculty members and dear colleagues. I am Dr. Devendra Singh from Department of Surgery, AIIMS, New Delhi. Before starting my talk, I would like to thank and congratulate whole of the organizing committee of Subharti Medical College and Professor Anurag Srivastav sir for organizing such a wonderful academic event and inviting me here for the talk on esophageal and gastric anastomosis. Initially, when I received the invitation mail, I was little concerned about the topic as it was quite focused. But going through the literature, I got to know that it is a very important topic for each and every general surgeon, as the incidence of anastomotic leak is highest after esophagogastric anastomosis to the tune of 10 to 40%, which is even in the hands of expert surgeon. Despite of so much development of medical science and technology, the leak rate remains persistently high after this anastomosis. Anastomotic leak leads to increased morbidity and mortality. The risk of redo surgery increases, which substantially increases the length of hospital stay and total cost. Anastomotic leak increases the anxiety and stress of both the patient as well as the surgeon. The term anastomosis is derived from Greek word ana means without and stoma means mouth. Thus, anastomosis refers to joining of the tubular hollow viscous like bowel or vessel to form a continuous channel without creation of a stoma. Intestinal anastomosis refers to creation of surgical connection of severed or separate bowel to form a continuous channel. I will discuss this topic under the following subheadings: brief anatomy of esophagus and stomach, which we are all familiar with, history of anastomosis, indications of anastomosis, types and techniques of anastomosis, and what are the factors affecting the outcomes of anastomosis. And the most important part is what are the principles of good anastomosis, finally led by the complications. So esophagus is a long hollow muscular tube measuring about 25 to 30 centimeter, extending from the 6th cervical vertebrae in the neck to 11th thoracic vertebrae in the chest. It lies in the posterior mediastinum. Anatomically, it consists of 4 parts: the cervical esophagus, the thoracic esophagus, the esophagogastric junctions, and the abdominal esophagus. There are three natural constrictions. First at the level of cricopharynx at C6 level, second at the level of aortic arch or left main bronchus at T5 level, and third at esophageal hiatus at the level of 10 thoracic vertebrae. These natural constrictions are the point where the foreign body usually impacts in the cricopharynx. The blood supply of esophagus is segmental, and the clinical importance of this lies in the fact that esophagus cannot be mobilized much along its length, and in most conditions it is resected in toto. And the condition which focally affect the esophagus, like Sajatki's ring or esophageal strictures, are dealt with endoscopic dilatation and not with the conventional surgery. The upper esophageal sphincter and cervical esophagus are supplied by branches of inferior thyroid artery. Thoracic esophagus is supplied by branches of bronchial arteries, and lower esophageal sphincter and distal esophagus is supplied by left gastric and left phrenic artery. Similar to arterial supply, the cervical esophagus drains via the inferior thyroid vein. The thoracic esophagus drains via the azygous, hemiazygous, and bronchial veins. The abdominal esophagus drains via the left gastric vein, also known as the coronary vein. The esophagus has a rich lymphatic network along its entire length, which facilitates longitudinal spread of malignant cells very rapidly in the early stage. The regional lymph nodes of esophagus extends from the cervical nodes in the neck to the celiac nodes in the abdomen. So it has a very rich lymphatic network. The stomach is a very highly vascular organ supplied by multiple arteries, like left and right gastric arteries, which are the branches of celiac trunk, the left and right gastroeploic artery, branches of splenic and gastroduodenal artery, and the splenic artery itself by giving numerous short gastric arteries which supply the fundal region. The venous drainage of stomach is through the left and right gastric vein, which drains into the portal vein, the left and right gastroeploic vein, which drains into the inferior mesenteric vein, and the splenic vein, which joins the inferior mesenteric vein to form the portal vein. The Indian history of anastomosis is very glorious and dates back to the time of great Shushruta in 6th century BC, who is also regarded as the father of the surgery. It is mentioned in Shushruta Samhita that Shushruta used to ask his mentees to collect big black ants in a jar, which he used for the purpose of bowel anastomosis. When the ferocious ants were taken close to the bowel, they used to close the bowel edges by biting it, and then one of the mentees used to behead the ant so that the edges remained approximated till the time of healing. Later, the use of red ants has also been described in the Western literature for the purpose of bowel anastomosis. The modern day surgical staplers which we are using are also based on the bite of ants, which form a B-shaped configuration to hold the edges of the wound or bowel. The major breakthrough contribution in the field of bowel anastomosis include in 1727, Philipp Ramdoher, a German surgeon. He was the first to successfully join the small bowel in a female suffering from incarcerated hernia. He stressed the importance of inversion of mucosa in bowel anastomosis. In 1812, Travers described the importance of serosal apposition to decrease the risk of anastomotic leaks. In 1826, Sir Antonio Lambert described the seromuscular suturing technique, which creates inversion of the mucosa with apposition of serosal layers. In 1867, Sir Joseph Lister, a British surgeon, also regarded as the father of antiseptic surgery, he was the first to use carbolic acid for disinfection of instrument used for the purpose of bowel anastomosis, which significantly reduced the incidence of anastomotic leak by decreasing the infectious complications. In 1880, Von Journey described the classic two-layered anastomosis, which we usually do, involving the full thickness internal layer covered by the outer seromuscular layer to decrease the risk of anastomotic leaks. In 1887, Sir William Halsted, who was the man of innovations, he developed many things like the surgical gloves, radical mastectomy. In the context of bowel anastomosis, he stressed the importance of submucosal layer and advocated single layer anastomosis, that is also known as extramucosal technique. In 1902, Connell described the technique of intestinal anastomosis using full thickness bites, leading to complete inversion of mucosal ends and approximate serosal apposition. In 1908, Hammer Huttel used the GI staplers for the first time, and for this contribution, he is also regarded as the father of stapler surgery. Interestingly, the stapler which he designed was weighing more than 5 kg and is a complex design with assembly time of more than 2 hours. So you can think how long with the surgery. In 1967, Stitchen and Ravitch developed the modern day surgical stapler which we are using currently. So the common indications for esophageal anastomosis includes carcinoma of esophagus or long segment stricture of the esophagus following gastric injury. Similarly, the common indication for gastric anastomosis includes some sort of bariatric surgery like sleeve gastrectomy, mini gastric bypass or Roux-en-Y gastric bypass, which all involve some sort of gastric anastomosis. Other includes the benign gastric outlet obstruction due to peptic stricture or carcinoma of stomach. The success of any surgical procedure not only depends on the mere good surgical technique, but also on adequate preoperative preparation and standard postoperative care. The preoperative preparation include resuscitation and optimization of dehydration by giving adequate intravenous fluids, correction of anemia by giving preoperative blood transfusion. The patient should be nutritionally built up by giving high protein diet either by enteral or parenteral route. The enteral route is preferred whenever feasible as it decreases the infectious complication by decreasing the bacterial translocation. Chest physiotherapy should be started in the form of incentive spirometry and steam inhalation. Smoking cessation must be advocated at least 1 month prior to surgery. Adequate antibiotic and DVT prophylaxis should be given to decrease the risk of deep vein thrombosis and pulmonary embolism in the postoperative period. And patient and attendant should be explained in great detail about the procedure and its risk, and informed consent must be taken. Bowel anastomosis can be of several types. Depending on the orientation bowel, it can be side to side, end to end, or end to side anastomosis. Depending on the technique, it can be either hand-sewn anastomosis or stapled anastomosis. The stapled anastomosis can be done either using a circular end-to-end anastomotic stapler or side-to-side linear anastomotic stapler. On the basis of part of bowel, it can be either gastrojejunostomy or esophagogastrostomy and so on. Based on the number of layers, it can be either single layer or double layer technique. The hand-sewn anastomosis can be either single layer or double layer. In single layer, it can be either interrupted or continuous. In interrupted, it can be simple full thickness sutures or Gambi or conal suture, which are a type of inverting sutures. The continuous suturing pattern can be either locking or without locking. In bowel anastomosis, usually the non-locking type is preferred to maintain adequate tissue perfusion. The double layered suturing can be either inner continuous or outer interrupted or inner interrupted with the outer continuous, and this all depends on the surgeon preference and his training. The preferred suture material for hand-sewn anastomosis is delayed observable like PDS or polydiaxonone or Vicryl with round body needle. The hand-sewn anastomosis can be done by various techniques, including the simple interrupted suture, the sero-submucosal suture or extramucosal technique, the serosubmuscular technique or Lambert suture, the Gambi and conal suture, which I will discuss further in subsequent slides. In simple interrupted technique, the needle is taken through all the layers from outside in, then inside out, and the knot is tied outside. The advantage is that it is easy to perform, but the limitation is that the mucosal inversion is not proper, and it usually requires a second layer for complete mucosal inversion. In serosubmucosal suturing technique, also known as the Halstead suture or extramucosal suture, the needle is taken through all the layers, excluding the mucosa, leading to proper mucosal inversion. I think connection lose हो गया उनका. In seromuscular suture pattern, also known as Lambert suture, the needle is taken through all the layers, excluding the mucosa and submucosa. The theoretical advantage is better perfusion of bowel as the blood vessels lies in the submucosal layer. The Gambi suture pattern is a type of mattress suture where the needle is taken through all the layers from outside in, then from both sides of mucosa, then taken out and knot is tied outside. Technically, it is more complex and not commonly performed. The conal suture is a type of vertical mattress suture and is commonly practiced at the ends of bowel to achieve perfect mucosal inversion and good serosal apposition. In this, the needle is taken through all the layers from outside in, then inside out, then from outside in and inside out, and knot is tied outside. So there is perfect mucosal inversion and serosal apposition. The factors which affect the outcome of anastomosis in a positive manner includes good nutritional and hemodynamic status of the patient in the preoperative period, healthy bowel ends with good vascularity, and accurate seromuscular apposition. And the factors which negatively affect the outcome of anastomosis include old age with poor nutritional status, patients on steroids, patients with anemia, uremia and diabetes, active smokers or alcohol abusers, anastomosis high in the neck like esophagogastric anastomosis, and low in the rectum as low anterior dissection are also at increased risk. Any hematoma formation adjacent to the suture line may also lead to increased risk of leak in the postoperative period. Based on the location, the esophagogastric anastomosis can be done in either the chest or neck. As per the literature, both are safe when performed using standardized techniques. The choice of anatomical location depends mainly on surgeon preference and somewhat to the location of the tumor. In general, cervical anastomosis has slightly higher leak rate and recurrent laryngeal nerve injury compared to the intrathoracic anastomosis. However, the leak in cervical region is easy to manage and does not lead to life-threatening mediastinitis, which may occur after intrathoracic anastomosis. And the possible explanations for slightly higher leak rate in cervical location includes the cervical location itself, which is more prone to tension and movement. When the patient tilts his neck, the anastomosis is under tension, compared to the intrathoracic location, which may compromise the blood supply and thus increasing the risk of leak in the postoperative period. Secondly, the cervical esophagus has less tissue surrounding it, making it more susceptible to disruption. In contrast, the intrathoracic anastomosis provides better support and stability. And last but not the least, the limited space in the neck also poses a technical challenge in creating a secure and tension-free anastomosis. This is the latest systemic review and meta-analysis published last year only, comparing the intrathoracic versus cervical anastomosis. It included 12 RCTs with around 1,500 patients. Anastomotic leak and recurrent laryngeal nerve injury were significantly less in the intrathoracic arm, and there was no difference in the incidence of complications like stenosis, pneumonia, and mortality. Hence, the author concluded that intrathoracic anastomosis is associated with the reduced risk of anastomotic leak and recurrent laryngeal nerve injury. This was a good RCT by Professor Vikram Kate from JIPMER, comparing the single layer to double layer anastomosis. The primary outcome was anastomotic leak. The secondary outcome were morbidity, mortality, and length of hospital stay. The author found no significant difference between the two groups in terms of anastomotic leak, morbidity and mortality, and length of hospital stay. Thus, the author concluded that single layer technique is feasible and alternative to conventional double layered anastomosis. Similarly, this systemic review and meta-analysis also showed that there is no difference in terms of anastomotic leak between the single layer and double layer anastomosis. The anastomotic time was less in the single layer technique, and the author concluded that considering the duration of the procedure and medical expenses, single layer anastomosis represents the optimal choice in most surgical situations. This is theoretical, but most of surgeons, we prefer double layer technique because we do not want to take any chance, and it is said that best postoperative care is given on the table itself. The stapled anastomosis can be done by various forms of staplers, which are coming nowadays, like linear non-cutting or transverse anastomosis staplers, the linear cutting or endo-GIA staplers, the circular or end-to-end anastomosis staplers, and the contoured staplers. In stapled anastomosis, the configuration of individual staple pin is in B shape, which should be neither too tight nor too loose to provide adequate compression without crushing the tissue, thus creating hemostasis without necrosis. To maintain adequate tissue compression, different staple heights are required as per the tissue thickness. For vascular controls, wide cartridge with a closed staple height of 1 mm are preferred. For small bowel and bowel with normal thickness, blue cartridge with a closed staple height of 1.5 mm are preferred. And for thick tissues like stomach or large bowel, green cartridge with a closed staple height of 2 mm is recommended. The modern day surgical staplers are equipped with various newer technologies to provide adequate hemostasis without causing tissue necrosis. These include the DST technology, the staggered technology, tri-staple technology, and the adaptive firing technology, also known as the tissue sensing technology. The DST refers to directional stapling technology. In this, the staple pins are made up of rectangular wire instead of the conventional round wire, and there is increased anvil bucket area. The anvil bucket area is the groove in the cartridge where the staple pin bends, and this leads to achieve more precise B configuration, which is our goal in stapled anastomosis. The round wire is more prone to bend in unintentional direction, In contrast, the rectangular wire, which bends more reliably in the intended direction. In staggered technology, the 3 rows of staplers pins are at different levels to maintain adequate tissue perfusion. As you can see in the image, the 3 rows of stapler are not in the same line, they are at different levels. In adaptive firing technology or tissue sensing technology, the stapler assesses the tissue thickness and adjusts the firing speed and stapler height, which leads to achieve adequate beak configuration. This technology is available in powered staplers like Signia, but the limitation is the cost. Each stapler cartridge and stapler cost around 1 lakh rupees. In tri-stapler technology, the 3 rows of stapler have different staple heights, with inner one the shortest and outer one the longest, which maintain graded compression and adequate perfusion. This is a commonly asked question in the MS examination, what is the tri-stapler technology, and the student usually answer there are 3 rows of stapler. It is not like so. You can see in the image in conventional stapler, the 3 pins are of same height, but in the tri-stapler or the modern stapler, they are of different levels to maintain graded compression and tissue perfusion. This is a recent systemic review and meta-analysis comparing the hand-sewn versus stapled anastomosis for esophagogastric anastomosis. It included 17 RCTs with around 2,300 patients with 1150 patients in each arm. The author found more leak and stricture in the hand-sewn arm compared to the stapled arm, but the limitation here was that the included study were very heterogeneous. There was no subgroup analysis of patients who had received neoadjuvant chemoradiotherapy, which may have resulted in the bias in the results. The pre-op and post-op care protocols were not standardized in all the studies, and hence these results should be taken with caution. This was a good RCT from our own center, where we have compared the outcomes of hand-sewn anastomosis versus side-to-side linear stapled anastomosis in neck. It included 174 patients with 87 in each arm. The primary outcome was anastomotic leak, and the secondary outcome was anastomotic time and stricture rate. We noted that the leak rate were comparable in the 2 arms, and the staple technique was faster to perform. The overall morbidity and mortality were similar in the 2 groups. This was a large systemic review and meta-analysis comparing hand-sewn versus linear stapled anastomosis for esophageal cancers. It included 15 studies with more than 3,000 patients. 2,000 patients had undergone linear side-to-side stapled anastomosis, and 1,000 have undergone hand-sewn anastomosis. The primary outcome was anastomotic leak, which was significantly less in the linear stapled arm. The secondary outcome was anastomotic stricture, which was also less in the linear stapled arm. Thus, the author concluded that the linear stapled anastomosis technique contributes to reduced rate of anastomotic leak and stricture compared to the hand-sewn technique. But this depends on the expertise of the surgeon. In the hands of experts, the results of hand-sewn and stapled anastomosis are similar. But for a novice surgeon, the stapled anastomosis has the advantage. The possible reasons for reduced leak rate in stapled arm in this study was mentioned that staple causes less trauma to the tissue, and staple technique being more faster. The stapled anastomosis provide a wider cross-sectional area, as the minimum cartridge length is 45 mm, so that it provides wider area of anastomosis, which leads to decreased incidence of stricture in the post-operative period. The tri-stapler technology of modern staplers maintain good perfusion across the anastomotic site, resulting in better result in terms of leak and stricture. Also, the hand-sewn anastomosis is technically demanding and not reproducible in all hands. This RCT compared the outcomes of stapler versus suture gastrojejunostomy. The outcomes were mean anastomotic time and leak rate. The anastomotic time was significantly less in the stapled arm. The leak rates were comparable in the 2 groups, and the author found that stapled gastrojejunostomy is better due to the reduced mean anastomotic time and less tissue handling. This large systemic review and meta-analysis comparing hand-sewn anastomosis versus stapled gastrojejunal anastomosis during laparoscopic surgery for morbid obesity, that is the Roux-en-Y gastric bypass. It included 13,000 patients, where 3,000 had undergone hand-sewn anastomosis, 7,000 circular stapled, and 3,500 at linear stapled anastomosis. The primary outcome was operative time, and secondary outcome was post-operative complications. The author found there was no difference between the stapled arm and hand-sewn arm, except for higher incidence of bleeding and infection with the use of circular stapler. The possible reason for that could be the need for extra enterotomy in the jejunum for introduction of circular stapler to create a gastrojejunostomy, which was not in the case of the linear stapler. Now coming to the most important part of the presentation, that are the principles of successful bowel anastomosis. They include, first of all, there should be good exposure. For that, stage sutures may be taken at the proposed site of anastomosis, and there should be good vascularity at the bowel ends with bleeding margins. For end-to-end anastomosis, any disparity in bowel should be matched with adequate chittling. There should be no tension on the anastomotic site, and the tissue should be handled gently. As it is a famous saying that if we respect the tissue will respect us in the form of good postoperative outcome. Use proper suture material and cartridges as per the tissue thickness, which I have told in the previous slides. In bowel anastomosis, rule of 5 is followed. That is, suture should be at least 5 mm depth from the margin and 5 mm distance from each other. The angle should be secured by starting suturing from both the sides and tying the knot in the middle. As leak mostly occurs at the angles, and these are known as the angles of sorrow. This I have learned from my various seniors, that when we do the anastomosis from one end and take the knot at the other end, the corner suture where we are completing the anastomosis, it is not under direct vision. So it is wise and better if we take the initial suture from both the ends and tie the knot in the middle. As a general rule, the distal patency must be confirmed prior to any anastomosis. Try to avoid mucosal eversion and excessive tightening of the suture, which may cause ischemic necrosis and later manifesting as anastomotic leak. Avoid post-operative hypotension and hypoxia, which may have deleterious effects on anastomotic healing. Correct the albumin and hemoglobin level in the preoperative period with a target albumin of more than 3. Hemostasis should be meticulous at the suture line with no hematoma, and try to maintain strict asepsis during the procedure, avoiding any contamination. Now, the complication of esophageal and gastric anastomosis can be divided into either early or late. Early complications include anastomotic leak, wound infection, intra-abdominal abscess, which is usually due to anastomotic leak, and the prolonged ileus. The late complications include stricture, which may later manifest as obstruction. Now, the recent innovation in the field of anastomosis is the use of magnets. The process called as magnemosis. This is also a recent question in a PG exam. The process of using magnets is known as magnemosis or magnetic compression anastomosis. It is a novel device for creating bowel anastomosis. The device consists of 2 donut-shaped magnets, which when introduced into the adjacent segment of bowel, creates a compressive force that leads to ischemic necrosis of the intervening tissue and leads to creation of lumen between the 2 bowel segments. Magnemosis offers several theoretical advantages over the conventional suture or stapling techniques, being less invasive, leads to faster recovery and reduced risk of complication. However, this procedure is in infancy and there are only case reports available, so it requires a lot of literature to support. Finally, to conclude, ladies and gentlemen, the success of bowel anastomosis is attributed to adequate patient optimization, meticulous surgical technique, and good postoperative care. In the hands of experts, the results of hand-sewn anastomosis and stapler anastomosis are similar, although the stapler anastomosis may be quicker to perform. Anastomosis leaks are associated with increased morbidity and mortality and substantially increase the length of hospital stay. So every attempt should be taken to avoid anastomotic leak in the postoperative period. Thank you for your time and attention. I also invite you all for our upcoming symposium on colorectal surgery at AIIMS New Delhi from 25 to 27th April, where there is a hands-on workshop also. Thank you once again, sir.
Thank you, Dr. Devin, for a wonderful presentation, I must say. What will you do? I simply ask for the postgraduates. You have said correctly the angles should be taken care of. What is the correct method to take care of the angles?
Sir, what I practice and learn from my senior is that from angles, I take the conal sutures from both the sides. Suppose we are planning to do a gastrojejunostomy, then take conal suture from the angles. After completing the posterior wall, then the knot is tied in the middle. Because I have seen many times other seniors also, which they are doing the laparoscopic field also. It is this principle applies both to laparoscopy as well as open. When you come from one end, then at the end of the anastomosis, the visibility is not there. So you go blindly.
Absolutely, absolutely correct, Dr. Devin. This has to be the take-home message that the angles must be secured. I'll add one thing to it. When you are at the mesenteric border, you have to tie the mesentery. the mesentery should be tied in such a way that the angle must be visible. A bigger stump of mesentery should not be there, a fine mesenteric ligation should be there, and the angle must be visible, and this angle must be taken in a conal suture. That must be the take-home message, whether you are doing interrupted or continuous, take this angle in a conal suture. Correctly you have said, sir. A simple thing I always say, there are only 4 things for the successful anastomosis which you have to take care of. 4th thing is the most important one. Number 1, your patient. He should be adequately fit for anastomosis. He should not have anemia or something like that. Look for the tissue. The tissue must be bleeding. It should not be under tension. Number 3, look for the suture material which you are using. It should be a good suture material, good length should be there. And number 4th, the most modifiable thing are the hands of the surgeon, which should be well skilled, well trained to do a good anastomosis. Stapled, interrupted, continuous, single layer, double layer, does not matter. What matters a lot is the skill of the surgeon. A surgeon who is used to, Halstead was used for doing a single layered anastomosis, but mind it, this single layer seromuscular submucosal is a very difficult bite to take on. It is just like driving a car, I must say. The person who is used to drive, in a way, he'll be driving like that for their entire life because he don't want to meet with accidents. Same with the anastomosis. Nobody will like to the anastomosis should leak. So he will do the anastomosis in the way which has always healed. Any comments, sir?
Rightly, Dr. Sanjay has said that 4 points should be well covered, and always I say, you observe and learn with your seniors and then practice one particular way, and if you find the success rate is more in that technique, follow that technique, because it may be single layer or double layer, but if it has to leak, it will leak. So practice in which you feel confident. Thank you. Thank you, Dr.
Thank you so much. Namaskar.
Thank you so much, sir. We are thrilled to have you here. Now I would like to request Dr. M.K. Maheshwari sir and Dr. Sanjay Pandey sir to felicitate Dr. Devendra sir.
Now I request Dr. Vipin sir to please come and felicitate Dr. Sanjay Pandey sir. Thank you, sir. I request Dr. Nivesh sir to please come and felicitate Dr. M.K. Maheshwari sir. Thank you so much, sir. Till now, the experience has been wonderful. We hope our audience is enjoying these skill-enhancing discussions. Moving towards our last panel discussion on complications of bowel anastomosis management, including fecal fistulas, we invite on stage the esteemed panelist for the next panel discussion, Dr. Deepak Singla, sir. Dr. Deepak Singla sir is currently working as Associate Professor in Department of General Surgery at Kalpana Chawla Medical College, Karnal. Dr. Anuj Sharma sir who is Professor and HOD of Department of Surgery. HOD of Department of Surgery, NCRIMS, Meerut. We are glad to have you here, sir. I would like to request Dr. Virendra Kumar, sir, Professor of Surgery, SMMS Medical College, Saharanpur, to please come on stage. Thank you, sir.
I would also like to invite Dr. Nivesh Agarwal, sir, as a moderator for this topic.
Yes, sir.
Very good afternoon. And just this panel discussion is between you and your lunch. So we will make it fast and understandable because our esteemed panel members are here. They will share their experience with you, which will have a lifelong impact on your practice and the surgical skills. So we'll discuss why it is important for having the panel discussion on the complication of bowel anastomosis. We have learned this intestinal anastomosis, gastric anastomosis, esophageal anastomosis. But what happens if this anastomosis doesn't stand? What happens? Then we have to how to manage this when the complications of bowel anastomosis are there. So common complications are anastomotic leak, fistula formation, bleeding, wound infection, anastomotic strictures, prolonged functional ileus, especially in the children. So I want to ask Dr. Virendra, how will you define the anastomotic leak?
Basically, anastomotic leak is a gap between at the site of the anastomosis when there is a communication between the interluminal compartment and the extraluminal compartment. So as per definition, there may be the fecal fistula, it may be the enterocutaneous fistula or fistula to the vagina or bladder. Patient usually present with the symptoms of septicemia with high degree temperature. It is a tachycardia. Patient is also, there is a radiological signs of anastomotic leakage are present, and this sign we will discuss when we will discuss about the CT scan and the X-ray. There is also the generalized peritonitis and the intraperitoneal abscess in the presence of an anastomotic leak. If any of the above symptom, if the patient is present with the pain, tenderness, tachycardia, and the symptoms of after a surgery, a feeling of unsatisfied, malaise, that may be that we have to be very high risk of suspicion for the anastomotic leak.
Okay, so we have to make in consider that these may be the symptoms when you're in the ward that this can lead to the having the patient having suspicion of the anastomotic leak. So it is the most feared complication, and any systemic or local factor causes delay in transition from inflammatory phase to the fibroplasia phase can result in poor healing and anastomotic leak. So Dr. Anuj, what are the risk factors for the anastomotic leak?
Sir, risk factors are arranged in various ways, but what I prefer to tell students is always we should think of two types, modifiable and non-modifiable. Because non-modifiable, anyway, we can't help it. And modifiable are the factors which we can work on and reduce the risk of bowel leak or anastomosis. So modifiable factors are the techniques, the most important thing. The techniques, though most of the studies says ki it doesn't matter what technique you use. What thing matters is you maintain the blood supply, you maintain it to be tension free, to maintain, and other things, patient profile. Malnourished patients are much more prone for the leak. Septic patients are much more prone to the leak. So you have to decide on table. If you are dicey, it can leak, then it is better to go for diversion.
Thank you. And Dr. Deepak, what are the other factors you see which can have the propensity for having this anastomotic leak?
So apart from the factors that sir has already mentioned, the setting in which the patient is presented to the emergency also matters. Like the patients for which we are doing emergency exploratory laparotomy, who have presented to us in shock, septicemic shock, they are more prone to have more risk of anastomotic leak. Apart from that, from the usual factors, I guess the patient's malnutrition, the nutrition status is also very important. Overtly malnourished and overtly overnourished means obese patients. They also have got a high risk of leakage. Then there are mechanical factors. If we are using especially stapler, then there are so many mechanical factors also which are associated with the leakage. Then there are chronic deficiency of vitamins and minerals which may also play a part.
So surprisingly, mechanical bowel preparation is also a risk factor for anastomosis. So how does this anastomotic leak present? They may present as loss of integrity of anastomosis and the leakage of intestinal content in three ways. It may be come to throughout the peritoneal cavity, uncontrolled. It may be formation of the enterocutaneous fistula. At least it is a controlled leak. They can come outside, you can see it and you can manage it and you know it, that it is there. Or it may be walled off by the peritoneal abdominal wall and other bowel loops, and it will be a sealed leaks. This is the most fearing of the complication, because very late you can know when patient is already debilitated, when going to know that there is anastomotic leak. So, Dr. Anuj, what are the warning signs of the leak? Sorry, Dr. Virender, what are the warning signs of the leak?
Actually, once one patient who is doing well after post-operatively suddenly present with the feeling of the malaise, tachycardia, high-grade fever, abdominal pain, and the symptoms of the paralytic ileus. There is a localized erythema around the wound, leukocytosis. There may be the wound dehiscence. There may be the pus discharge or feculent discharge from the drains. They all are the warning sign of leak. Patient may land up into the anastomotic leakage site.
So we have to care to take that all this should not be there. If there, then we have to be alert that there may be anastomotic leak. So, Dr. Anuj, how to diagnose? We have in the ward, we have seen all these signs, as Dr. Virendra has told. How will you diagnose? How will you confirm your diagnosis that there is anastomotic leak?
Sir, the very basic investigations which you can do bedside also is ultrasound, which will show you the collection. And obviously blood test will show you the signs of septicemia will be there. Patient will be in distress, as Dr. Virendra told. And the most ideal diagnostic confirmed investigation is CCT abdomen, and which is very easily available nowadays at every places.
So nowadays CCT is considered to be gold standard, because we don't have the time to lose. We have to get the CCT done, see for the leak, and now approach aggressively to manage this anastomotic leak. So, Dr. Deepak, what are the CCT features which can tell that this is the leak of the anastomosis?
Most commonly, if there is a strong clinical suspicion of an anastomotic leak, CCT shows extravasation of contrast, which we have given orally. So that is the first thing that is visible on the CT films. And apart from them, there may be collection of fluids in the various spaces like pelvic space, subhepatic space, and paracolic gutters. And I guess there may be exaggeration of normal pneumoperitoneum, which is present post-operatively. So these are the signs which may be present in CCT whole abdomen.
So already this has been there is an issue when you are in the emergency, when you are elective doing the anastomosis. What should be the suture material for anastomosis? Whether it should be absorbable, non-absorbable, monofilament, multifilament. So it has been seen that monofilament and coated braided suture represent advanced beyond silk and multifilament materials. So the ideal suture material, one that causes minimal inflammation, tissue reaction, while providing maximum strength during the lag phase of the wound healing. That is the initial phase of anastomosis. If we have to take that material for the consideration. So, Dr. Virendra, what are your preferences, continuous or interrupted? We have multiple discussions in the hour, but what is the take? Whether you go for the continuous or interrupted?
There are many studies, but no way of method is superior to the other method. It actually depends upon the personal choice. But as such, in case of the interrupted suture, oxygen tension is much more compared to the continuous suture. But in case of if there is a very high vascular region, such as when you are doing anastomosis between the stomach and the jejunum, we always try to use the continuous suture.
Okay, so again, as previous speakers also reiterates that it is surgeon's choice. They want to go the continuous, they want to do the interrupted. It is their choice, and accordingly, in which they are doing continuously, they are doing the surgeries as they do anastomosis. They take any one method. their preferred method and continue to do that method.
Sir, I would like to add one thing here, if you can permit.
Yes, yes, please.
Continuous sutures and single layer and double layer. It is initially when we were taught in PGs, we used to do continuous, double layer, sometimes even triple layer. And when I was doing SR-ship, we had a workshop by Dr. Chintamani and he told कि भाई single interrupted sutures लगाने हैं और कुछ नहीं करना है. It seems so easy कि what we keep on doing, हम इतना time लगाते हैं, patient का anesthesia, patient already tension में है, तो but हम trust नहीं कर पा रहे थे. But one of our colleague was there and he told कि नहीं, I'll do like this. And did some, I don't remember, ileal perforation or duodenal perforation we did, and third day there was a drain was showing feculent matter and our professor was shouting on us कि तुम लोग नई नई चीजें सीख के आ जाते हो, and it was like this. And but जब उसको खोला गया तो that anastomosis was intact. There was a iatrogenic perforation somewhere else. So that's what I want to say कि it really doesn't matter, but it makes life very simple. For your next answer, single layer interrupted sutures, what I am following since ages now, and I haven't found any difference.
It's very true, as in the morning also Dr. Anurag sir was saying that why to waste the time on the double suture and multiple. So it is the single suture which is single layer suturing which is now trending and it's in following all over. Because it is traditionally it was seen that double layer sutures having the more secure, but it has seen that macroscopic area of necrosis and sloughing are there. Also, single layer suture lacks time to create, has got the more rapid revascularization, mucosal healing. There's increased strength of anastomosis in the first few operative days. So, Dr. Deepak, can you tell us, is there any role for the double layer suturing anastomosis? Do you feel that any area, or you agree with that in all cases we have to do the single layer?
So personally, we also been following this trend of single layer suturing over the ages. But then, especially in the cases of redo exploratory laparotomy, or where the patient has presented late in the where both the bowel ends are edematous or they are friable, there we prefer double layer suturing. And of course, in the highly vascular areas in stomach, where the hemostasis needs to be attained very meticulously, and of course tissue, whenever you have a anastomosis under tension, so there you need to safeguard your anastomosis. So we always prefer double layer anastomosis in these cases, sir.
So dictum is that we have to do the single layer until unless these are the conditions where if it is depend on the operative surgeon whether a single or double layer, but if these are conditions you can consider going for the double layer. So we have also discussed in length about the hand swan or stippled. There was many studies, previous speakers has said that, and it came to know that there is no differences in the clinical and subclinical. Still it is going on. Stippled companies are preferring that no, our are more better. Hands when old surgeons say no, we believe on our hand, we eat by our hand, and we'll do the suturing by our hand. Why to take the, we are the Indians, we are doing the eating by our hands and we'll do suturing also by our hand. Why to take the spoons and the knives and the cutleries? So, but as there is no difference, it is the preference of the surgeons, and in which again he is more comfortable. But I suggest that as a surgeon you should be having experience of both. And in an event where you require, there's requirement and there's need, or you can change to the traditional or as well as in the hand swan. So what is your take on the bowel preparation, Dr. Virender, whether bowel should be prepared or not, or what to be done?
Traditionally, bowel preparation make the life of surgeon much easier, as we can handle the bowel easily. It will make the field clear. And mainly if we are dealing for the any growth, we can palpate that growth against the, if bowel is empty. But the main thing nowadays, the concept is that because of the bowel preparation, it increases the chance of the immune change in the bowel mucosa, and it interferes with the healing process. So, but one thing we have to be very much clear, if in case of bowel preparation, if there is any growth, any snoozing growth, any growth that is occupying the lumen, we must avoid the bowel preparation, because in this case most of time after bowel preparation patient is not able to pass the feces properly, and it will make the life much hell.
Thank you. So Dr. Anuj, as you have given your experience about the whether single layer or double layer, what about inversion and eversion of the anastomosis?
So it's always inversion. What we have studied, what we have followed, and what we have seen, very few studies I have read about that too when you said we will discuss about it. तो मैंने फर्स्ट टाइम पढ़ा था कि एवर्जन भी हाँ लोग प्रेफर करते हैं एंड कई जगह होता है, बट आई हैव नो एक्सपीरियंस ऑफ इट. सॉरी.
Okay. Dr. Deepak, what about the nasogastric aspiration post-operatively? Because as surgeon, we are very fond of putting each and every catheter in each and every holes available in the body. So through the urinary catheter, flatus tube, nasogastric tube, drains, whatever we have available. So what do you take on the nasogastric aspiration?
So nasogastric aspiration, all the available literature, it strongly advocates against putting nasogastric aspiration. And the irony is, it is being used for decreasing the period of paralytic ileus, but it surprisingly increases the period of post-operative ileus. First thing, and then the chances of respiratory infection, aspiration, pneumonia, and everything is also increased with putting Ryle's tube. And so, all the literature shows the use should be not be advocated. So we do put Ryle's tube in selected cases, of course. Then
in our institution, we follow that clean cut cases where we're doing the allostomy reversal, colostomy reversal, or clean anastomosis. We don't put the nasogastric tube. Only cases where we suspect that there can be gastric dilatation, gastric paresis, then only we put the nasogastric tube and try to remove as early as possible. Or otherwise, we don't follow the. So. Also, like nasogastric tube, we have also got the issues whether drain should be put or not. So it has been seen that it is must in the emergency operations for the peritonitis or trauma in which necessity to close or anastomosis damage or inflamed bowel. In other cases, it depends on the surgeon's decision, but it is to be drained for the time which is required, and it has to be removed as soon as possible, because it has been seen that as soon as because if drain we have the drains near the anastomosis, then it causes the more of the disruption of the anastomosis due to the infection. So drain has to be, not to be put, and if put has to be put minimal. Once its work is over, then it has to be removed. So Dr. Vendor, what do you say? What are the sites we suspect when doing the anastomosis that having the maximum chances of leak?
Most of leakage is present in case of the if we are anastomosing the distal rectum. And the rectal anastomosis have 6 to 8% higher chance of anastomotic leak compared to the colonic anastomosis. In case of the esophagus, because of the lack of serosa, and in case of the pancreatico-enteral anastomosis, because of the nature of the secretion, it is a very high chance of recurrence. So when we are doing anastomosis in these three areas, we should be have highly suspicious that patient may leak.
So it is very important that above the peritoneum and below the peritoneum, you should there is chances of leak, so we should go for the best of the anastomosis with meticulous suturing, so that they should not be leak. And also because these pancreas secretions are there such like, so we have to do the take the care. Also sometimes what happens when we do the emergency surgeries, we are doing the splenectomy, there can be damage to the splenic tail, which can lead to the pancreatic secretion, or we are also damage to the stomach. So there, when we are achieving the hemostasis and we are achieving the other repairing the bowel or repairing the stomach, we should use the non-absorbable sutures, because if we use the absorbable sutures, they will be digested by the pancreatic enzymes and there will again leak. So it has to be taken care of. So what are the role of defunctioning stoma? Dr. Anuj, is there any role?
Yes, sir. But I have a question to you here. So why defunctioning stoma? Why not we get that perforated site out?
Very good question. And what is the issue? Sometimes what happens, we have got well repaired. We have repaired we have done the anastomosis. And suppose there is anastomosis we have done in the deep in the pelvis or in the sigmoid colon, where colonic anastomosis have been done. But due to some infection, due to some technical disadvantage while doing the surgeries, there may be certain things.
Elective surgeries
in the emergency surgeries. Suppose some technical error is there, we have repaired it, but we want to protect our stoma, because going again for that thing, doing the whole laparotomy is very difficult. First thing. Second thing, if some areas where we can't externalize, so if we're doing the colonic surgery, doing the rectal surgery, we do that surgery and externalize the ileum or the proximal colon. Later on, it is very easy for the surgeon as well as the patient that we can just close it from the local side. Otherwise, we have to again go for the full laparotomy. Suppose we have done the, suppose heart's been done, we have done the loop allostomy or colostomy. Then again, we have to do the full end allostomy or the end colostomy. Then again, we have to full laparotomy and we have to operate.
So the take-home message is in elective surgeries where we have a risk of anastomosis, we should do a defunctioning stoma. And in emergency surgeries, we should take the perforated bowel out rather than if you want to create a stoma.
It depends on, suppose in the emergency we have got the obstruction mass is there and we are able to resect it and do the anastomosis. But in the emergency surgery as patient debilitated, we can have the defunctioning stoma to be careful for the patient well-being. In elective surgery, it is our choice. If it is surgeon feels that there is some misadventure during the surgery, then they can have the defunctioning stoma, otherwise it is not required.
Yes.
Yes. Yes, sir.
For your thing, the studies have shown a proximal diversion will never prevent leakage. If a leak has to occur, it will occur. But the problem is, especially for the left side of the colon or rectum, when we are operating, a leak occurs, it may be fatal to the patient. So by decompression, we are not preventing the leak. If the leak is occurring, exactly. That is the take-home message.
So morbidity and mortality, and also for the resurgery when we have to again make the continuity of the bowel. Dr. Deepak, what you will say about the summary to avoid the leak? How will you summarize that? What should be our proper procedure to avoid the leak?
Sir, the anastomosis the tissue should never be in the tension. Adequate exposure should be there. Adequate dissection of the tissue should be there, and there should be all the aseptic precautions should be followed during the surgery. And patient's pre-operative nutrition status, if it can be improved, that will be icing on the cake.
So again and again, all our esteemed speakers are saying that we have to take care proper. There should be no tension, proper suturing, proper knotting, no infection. All this care has to be taken, because once we are doing the proper anastomosis, then there is least chance for having the anastomotic leak. So this dreaded complication should not occur to the patient. But if occurs, then we'll see to it how to manage. So you have to better avoid anastomosis. Also, it is important that anastomosis is there. But if we don't, in these patients, we have to better avoid the anastomosis. We just do the ostomies, like in a hemodynamically unstable patient, immunocompromised patient, nutritionally depleted patient, where have the fecal peritonitis or where edematous and the ischemic bowel. In these cases, already patients are debilitated and again leak will be fatal for the patient. So better go for the allostomy or colostomy or ostomies instead of doing the anastomosis. Later on, when patient is came out these circumstances, go for the anastomosis. So once leak is there, then we have to manage the case. Then as per suspicion, we have to, patient comes to emergency or patient is in the ward, immediately resuscitate, correction for the third space loss, make it patient NPO again, blood transfusion is required, broad spectrum antibiotics has to be given, and after that we have to take a decision. So Dr. Vinder, when you take the decision to reoperate or when to manage it conservatively?
Early and judicious early surgery can save them many lives, and one of the most important thing is that if the patient is developing diffuse peritonitis. In case of diffuse peritonitis, it's better to always operate the patient. If the patient is having symptoms of intra-abdominal hemorrhage, if there is a signs, there is suspicion of the intestinal ischemia, and if there is a major wound disruption or evisceration where the loop of bowel is coming out, in this case we have to decide for the early reoperation. But one thing we have to be very much clear that in this case reoperation has very high mortality and morbidity, so everything should be properly explained to the patient and their attendant.
Thank you. Suppose there is a leakage and there is a patient debilitated, there is in the ward, then how will you make the damage control? Dr. Anuj, please.
So damage control in anything, even it is a trauma or we are suspecting a bowel leak or any ischemia, it just means we are doing a surgery just to safeguard the life, reduce his sepsis, reduce the contaminated products in the body, and wait for 24 to 48 hours, let the patient be on ventilation, and then again you go for re-laparotomy. And then decide further management, whether you want to anasmose, whether you want to create a fistula, whatever it is.
Very true. In the disaster control, we have to save the life and the limb. So first, we have to maximize patient and nutrition, patient's well-being. We have to, whatever infection we can remove, we have to remove it. Then only we again think of the making the anasmosis and other things. And in this, if we in anasmosis, if we do the omentum, and then it will be helpful in the anasmosis. So now we come to the another dreaded thing, which is the fecal fistula. So Dr. Deepak, how will you say what considered to be as fecal fistula?
Fecal fistula actually is nothing but it is a enterocutaneous fistula. It's an abnormal communication between the bowel loop and the skin. And most common loop that is affected is distal bowel, and most common organ affected is ileum. So it's an abnormal communication most commonly between the skin and ileum.
So when this enterocutaneous fistula occurs, it is both devastating for the surgeons as well as the patients. And they came on just hammering on you that what this happens. So there are certain risk factors which you consider that it can lead to the fecal fistula. Like preoperatively, there may be previous abdominal surgery, malnourished patients, surgery for inflammatory bowel disease, septic patient or acute sepsis, steroid use, interabdominal abscess. And perioperatively, the patient may be in the shock, there may be extensive adhesional lysis, or there may be injudicious anasmosis. In postoperative, there may be repeat laparotomy. So all these lead to the risk of enterocutaneous fistula. So if you are in these cases, if you are not comfortable, then go for the ostomies instead of doing the anasmosis. So, Dr. Viren, how will you classify the enterocutaneous fistula for the benefit of our PGs?
We can divide on the basis of the physiological high risk, high output and low output fistulas, depending upon the anatomical classification and depending upon the primary cause and the secondary cause. In case of the anatomical classification, it may be two types. It may be internal fistula or external fistulas. Internal fistula just between the two organs, it may be the gastrocolic fistula. In case of the external fistula, it may be depending upon the enterocutaneous fistula. On the basis of physiological, it may be the high output fistula if the output is more than 500 ml in 24 hours. In moderate, it is between the 200 ml to 500 ml, and the low output fistula when the output is less than 200 ml. Apart from that, maybe because of the primary cause and the secondary cause. Primary cause if there is because of the Crohn's disease or because of the malignancy, and the secondary cause may be because of the trauma, because of after surgery. It may be the second case of the secondary cause.
Okay. Please, can I have silence from? Please, request. Please do not talk. Please.
Like the patient may be in renal failure or liver failure. So these sort of patients, they have a high propensity of fecal fistula. Then of course the status of the bowel, whether it is diseased or was it normal physiologically. Then of course the features of fistula, whether the site of fistula, the number, the length of fistula, and of course whether from which side it seems to have originated. So there are so many factors.
So if we have got, these are the factors, if we have got a favorable factor, we can wait and watch and let it be healed by itself. Small leak, it can be healed by itself. But if it is unfavorable, then we have to consider early for the re-exploration and the re-anastomosis. So chances of spontaneous closure fistula is there when there is low output, less than 500 ml, it can be spontaneously closed. If it is high output, then it is less chances of closure. So we have seen that 90% of small intestinal fistula, they close spontaneously within a month, and 10% fistula closes spontaneously after 2 months and then after 3 months. If 3 months there is no closure, then you can consider for the re-exploration. Factors as told for Dr. Deepak against the fistula healing is foreign body, radiation, inflammation, infection, epithelialization, neoplasm, distal intestinal obstruction, and steroids. These are for all the fistulas. Where it is present, all these factors are there for non-healing of the fistula. So, Dr. Virendra, what should be the treatment of fistula? Now we are discussed about the cause, diagnosis.
Fistula is one is very traumatic for surgeon too, along with the patient. So basically, it's a properly teamwork where we need a surgeon, good staff, a dietitian, stomach therapist, and even a psychological counselor for that. The first thing is always resuscitation of the patient. Prevention of the leak formation, total parenteral nutrition. We have to correct the electrolyte imbalance, antibiotic therapy, and if there is a localized collection in the peritoneal pouches, just such as in the pelvic collection of the pelvic abscess, subphrenic abscess, we have to drain that particular abscess to relieve the symptoms.
All these are there. First, we have to try to treat conservatively, and if the factors are not favorable, then we have to consider for the. Dr. Anuj, what do you say that the basic concept for management of fistula?
So as Dr. Virendra said, basic concept is you have to first of all control the sepsis, maintain the nutrition and electrolytes and all things of the patient, and observe clearly. Do not be very aggressive to reoperate until unless you can wait to almost 1.5 months if it is a low output fistula, and you are able to manage its nutrition and sepsis. So that's the key thing.
So we have to stabilize the patient, sepsis control, skin care, give the nutrition to patient. Then again, if we want to operate, then we have to evaluate for the anatomy of the fistula. For that, what we have to do, we have to do the CCT. And then we have to plan then how to deal the fistula. Also, pharmacological agents like somatostatin, octreotide, proton pump inhibitors, they are also used to decrease the secretion and to avoid the complication of the fistula. So, fistula anatomy can be examined, studied, and after that we can treat the patient. If conservatively it is not managed, up to 3 months it is not being spontaneously healed, then we have to operate. So, Dr. Deepak, what are the, if you have to reoperate, what are the principles of surgical treatment for fecal fistula?
So far, sir, our experience says the basic things remain the same. Whenever there is a patient with fecal fistula, first we have to ensure that the bowel margins, they are not inflamed. We have to take care of the infection, and then the nutrition part, that takes the first priority in such patients. So we have to optimize the patient. We have to build up the patient, and then we have to drain all the sources of infection. And then while reoperating, we have to make sure that the anastomosis that we do, it is not under tension, and accordingly we have to plan seeing the status of the tissue intraoperatively, sir.
So, basic principles, as Dr. Deepak has elaborated, that we have to resect the intestinal segment, fistular tract, and the adjacent part of the node structures. We have to see that there should be absence of extensive infection and inflammation, and primary anastomosis of the divided intestinal segment and re-establish the GI continuity. So, presence of extensive infection, if there, then divided anastomosis can be externalized. That we can again do the ileostomy or colostomy and then wait and then again go for the anastomosis. Stage procedure is better as compared to just go for re-anastomosis. We have to re-examine, re-look and reconsider. Then only we have to do the re-anastomosis. So aim of surgery is to restoration of intestinal continuity after resection and construction of the abdominal wall, because we have got two concepts. One is to maintain the integrity of the bowel, and second is to reconstruct the abdominal wall defect. So what happens sometimes abdominal wall could not be closed. If not closed, then we have to do the component separation and we have to close the abdomen. So how to prevent the enterocutaneous fistula? You well know that through proper anastomosis it can be cured. We have to care meticulous surgery without any much of the extensive adhesion laces, optimize patient condition, then only we should go for it. So Dr. Virendra, what are the bleeding complications in the management of the anastomosis?
In the post-operative phase, patient present with the hypotension, there is a blood in the nasogastric tube, patient may present with the hematemesis or melena, or there is a blood, high output amount of the blood in the drain. Then it indicates that maybe the chance of the bleeding from the anastomotic side. In this condition, first of all, we should try resuscitate the patient. We should try to correct the, if there is any coagulopathy disorder, we should properly arrange the blood, and if still that patient is still bleeding and patient is still in hypotension, we should re-explore the patient, and we should, in such circumstances, the anterior layer of the suture is opened, and we should properly examine the site of the anastomosis. If there is, we identify the site of the bleeding, we should apply the hemostatic suture at that site. If patient's condition is not good, patient is in a critical condition, it is always better to convert the anastomotic site into a stoma site.
Thank you so much. So this is the thing. First of all, we have to take meticulous, when you are doing the anastomosis, wait for some time, see that there should be no bleeding, because if it is concealed bleeding, patient is already compromised, it can lead to devastated effect on the patient. So when you are doing anastomosis, hemostasis should be achieved very meticulously. And if it occurs, then you should be very early to diagnose it and to treat it. Dr. Anuj, what are your take on the wound infections?
Sir, in emergency perforation surgeries, wound infection is one of the most common thing we see almost in every patient. So we should be very observant about it. And as we were discussing, drains are still doubtful. And I am sure 9 out of 10 people will still put drains in any bowel surgeries. But I have a personal experience that proves that drains usually don't drain. Ileal perforation, young girl, and it was a pelvic drain was placed, 28 size, and patient developed high-grade fever. Fortunately, after waiting, we improved the antibiotics and all those things, and we did a scan, and there was a collection, 400 ml collection in paracolic gutter, which was not coming to the pelvis and not being drained. तो ड्रेन कई बार ये भी कंफ्यूजन कर देता है कि वी आर वेरी कॉन्फिडेंट कि कुछ होगा तो ड्रेन से आ जाएगा भाई, बट ऐसी भी चीज़ें हो जाती हैं. एंड पेशेंट लैंडेड टू सेप्टिसीमिया बिकॉज वी मिस फॉर 24 to 48 hours, एंड देन शी स्टार्टेड ब्लीडिंग, जो अभी बात हो रही थी. एंड पेशेंट took to refer to higher center, and at higher center she was reoperated for bleeding, and finally her PT came out to be is very high. That was thrombocytopenia, pancytopenia due to septicemia. उसका bleeding का कारण वो था. But anyway, patient survived luckily. So बहुत सारी चीज़ें हैं. Wound infection is very common. अगर superficial wound infection है तो you should be very vigilant and open the sutures and let the pus drain. पस जहाँ भी हो उसे निकलना है, तभी चीज़ें settle होंगी. And keep on doing regular ultrasound if you have doubt, leukocytosis, TLC count repeat करते रहना चाहिए. Even if you are not doubting and patient is not comfortable, something is there. So you should be very vigilant about it.
So Dr. Virendra and Dr. Anuj has told you that you should be very suspicious in the ward when anastomosis is done. Any clinical features are there, patients not responding, patients not comfortable, always suspect anastomotic leak until and unless proved otherwise. And if required, take help of your radiologist friend and get the ultrasound done if you're not feeling that there is something is wrong with the patient. Okay, what Dr. Deepak, there is another complication which is the anastomotic strictures. So what do you say, how to avoid it, and if it is there, how to manage it?
So in our experience, it is also it is most commonly found in large bowel surgeries, and that to the distal, the rectal surgeries. So here it can be managed both with the help of endoscopic dilatation, that is one option, or as the recent literature says, there is a classification that digital rectal examination also, anal dilatation, it also helps a lot in the management of these strictures.
As Dr. Deepak has said that how we come to know that there is a stricture, clinically patient will present that subacute intestinal obstruction. We have to be careful, and by doing the CCT, we came to know that the stricture is there. We can do the colonoscopy or other endoscopic work, and if we suspect that this stricture is there, then we have to either try to dilate it endoscopically, or we have to reoperate that part. So in this regard, it is also important that it is seen that with the stapler anastomosis, this stricture is far less as compared to the hand swell, which recent results are being showing. So in these cases where we're not sites are not approachable, like in the deep pelvis, like in the chest with an esophageal anastomosis, we can use the circular and the other staplers for the anastomosis. So in concluding this of our esteemed panelists, what they said that principle of successful anastomosis should be there, that patient will be well nourished, with no systemic illness, no fecal contamination. We have to do the adequate exposure. We have to get the well vascularized tissue for the anastomosis, and there should be no tension on the anastomotic site. And take home message: leaks are common. Don't afraid from it. Try to make the high index of suspicion. Manage aggressively and safely. Leaks are better avoided than treated. So try the meticulous anastomosis instead of later on managing it. Over meticulous surgery is harmful. Stick to the basic principle of surgery with smooth handling of tissue and better pre-operative preparation. As previously sir has told that if you respect the tissue, tissue will respect you. Thank you so much. Any questions from the panelists you want to ask? I think in this extensive they are given their lot of surgical pearls for you to follow. And if any questions you want to ask or any opinion you want to, thank you so much. Thank you, panelists.
Thank you again, sir, for guiding us with this topic. Now I request Dr. Nivesh Agarwal, sir, to felicitate Dr. Deepak Singla, sir, Dr. Anuj Sharma, sir, and Dr. Viren, sir. I request Dr. Deven, sir, to felicitate Dr. Nivesh Agarwal, sir. Now we have come towards the end of today's session. It was a privilege for all of us to be a part of this event delivered by such wonderful surgeons.
Now we request you all to please proceed for lunch, followed by the workshops after it. Thank you so much.